I'm Bill Vicenzino, current director of the Master Physiotherapy program, and we always get quite enthusiastic and excited about having our end of semester conference, and this one is the Musculoskeletal Physiotherapy conference for our master's graduates. As is customary these days, I'd like to acknowledge the traditional owners and their custodianship on the lands in which we meet today. I pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. Well, I'd like to issue a warm welcome to everyone that's joined us today, particularly any educators on our programs internally out here at St. Lucia, or those of you in clinics that take our students. You play an invaluable role, and particularly in the master's program. And it was quite pleasing that our external assessor for the accreditation of our musculoskeletal physiotherapy program commented and praised highly the standards set by clinical educators when he observed them a week or so ago. So welcome if you've made it tonight and you don't have any other children to chase around or other things on. I'd also like to welcome all students, particularly those at UQ, but also from other universities and also other postgraduate programs. A particular and special welcome to those of you who have graduated from our program and come back almost every year to the conference to support your new colleagues. Thank you very much for making the effort. I'd also like to thank and acknowledge those students that are currently in Part A or yet to complete Part B, which is the part that the students presenting today are in, for making the time also, as it's not part of your curriculum, but thank you very much for coming along. And it would be very remiss of me not to thank the management committee of this master's program, who play a large role in making sure the quality and the content is up to scratch. So hoping not to forget anyone, but Ziggy, Vienna, Michelle, Julia, Sean, in particular, special mention to Michelle Smith, Associate Professor Michelle Smith, who will take over the director role starting semester 2 this year as I step away from that position. So thank you very much, everyone, for coming, and a very warm welcome, and what looks like a very an excellent keynote and some really nice topics chosen by the students this year. So I'm going to go through and do a little spiel on, just while people are coming into the room, a little spiel on the master's program, the webinar, how it runs tonight, before I get to introduce the keynote speaker for tonight. So the next 5 or so, 8 minutes, hopefully, that I'll go through this. So the Master of Physiotherapy program is one which is run here at the University of Queensland. It's been run for a number of decades now. We have majors or streams of musculoskeletal physiotherapy and sports physiotherapy. The whole idea is to develop critical thinkers and advance skills and critical thought through coursework, clinical placements and research. We try to engender evidence-based practice, biological, medical and behavioural sciences are brought into it, and a theme that runs from the first module of the online component through to the end is the clinical reasoning. It'd be remiss of me not to mention that UQ is ranked number 2 in the world and number 1 in Australia for sports-related subjects on the QS World Rankings. It's got by subject 2023, but it's also by subject 2024. So what do you need to become, or what are the entry requirements to come into the program? A bachelor's degree or equivalent in physiotherapy and a minimum of 2 years full-time equivalent professional experience. When we're looking at, because positions are competitive, when we are looking at applications, we do value highly the kind of experience you have, the level of responsibility you take in those employment positions, your continued professional development, as well as your scores from your academic career. So it's a pretty broad-based assessment process. And we interview applicants after assessing the written. So we aim to make sure that students coming into the program are in a good position to do the program, and that we're not going to encounter difficulties along the way. For the domestic students, places are Commonwealth supported, and that means government subsidises a significant portion of tuition fees. We take both domestic and international students, and there was a little bit of a mix-up when we went to our current program through visa regulations, et cetera, but we are now in the position that we're taking and looking at more international students. So if you are in the room and you're interested in the program, if you've got your camera handy, I'll pop up this QR code again some other time tonight, I think. So you could take a snapshot there, and it'll take you to the website, the UQ website, where it explains and where you can get more information, and you can contact us to get more information. Deadlines for applications are 1st November 2024. But please note that we assess applications as they come in, and those applications that are ranked highly above a certain cutoff score, we make offers immediately. And so don't leave it to the last minute, because our positions are capped, unfortunately, because we have limited positions to take students. Like for clinical placement, we only have so much capacity. And so, like I said, it is competitive. Get in early if you're thinking about it, or at least talk to someone and get all the baseline information that you need to make a decision. Okay, just a little bit about the Master of Physiotherapy program. What are you going to expect? What are you going to do and expect if you sign up for it and you successfully offered a position in it? So semesters 1 and 2 are done totally by distance, remotely, online. And it involves allowing you to do part-time work while you study, remembering that it is half-time, so you do half-time work, half-time study. We actually tailor the learning activities around the fact that you are working. So it's an integrated work-study experience that we're trying to develop, and we feel that generates better and deeper learning situations for students. We don't have lectures that you have to turn up to, but we do have weekly short webcasts, which are stimuli with learning activities, readings, and things to do around those webcasts every week. The courses we cover online are evidence-based practice, clinical reasoning, pain biopsychosocial model, exercise, therapeutic exercise, the biomedical model. And some of the things that students really seem to thrive in is some of the interactive debates and discussions that we have. So while majority of the online component is done asynchronously, in other words, you don't have to be in a spot, you don't have to be online at a certain time. The assessments, the end of semester assessments, are all done live, as are some of the mid-semester assessments. And we have debates where we had one, we finished up 7 course last night, the pain course last night. We had a debate to finish off that course, and that was online. We had 6 students, 3 aside, and every student does that. So that's the online component, goes over a year, 2 semesters, so that's 4 courses. And then the sports and MUSC are done over the ensuing year. And so there are similarities between these programs, but they're done at different times. So content is tailored for sports or MUSC. So this is full-time on-campus face-to-face learning here at St. Lucia. It's a great campus. So if you it's not as bad to get away from your local place for a 3-month period, 3-4-month period. We have supervised placements under title and specialist physiotherapist. We have problem-based learning and discussions and practical classes, all the things you'd expect to increase your skill level and knowledge level as a expert master clinician. And the courses go along the lines you'd expect. There are prac classes, there are problem-based learning things, there are clinical reasoning, research. There's a bit of research in it as well. Sports do a lot more that are related to athlete management and exercise prescription. And the Musk do a lot more complex pain conditions and presentations. So that's the kind of mix. If you're wanting to know what's the difference, it's best to talk graduates of the program, recent graduates, because the program changed about 6-7 years ago, and have a chat to some of the staff, and we'll give you some insights into how things are different. So some of the fundamentals when we designed this program, I think it's about 6-7 years ago, some of the underlying, we got feedback from potential students and past students, and some of the feedback we got back is that students weren't able to disrupt their social network, families, etc., to come on campus for a whole year full time. So that's why we've got half the program online. So you can maintain your social context, your family unit, your friend network, etc., etc. Also, you can keep on working, so you don't have such a financial hit. Not that our program is that expensive, and with CSPs, it's made a lot easier financially. Like I said, we value and we place highly clinical practice and clinical engagement as a learning experience, and trying to integrate the learnings from the theory and from the other learning activities into your practice. And when we interviewed people about what was best and needed to be kept on going with our program was the supervised practice. In other words, where you go to practice, manage a caseload, and have no more than 4 students to 1 expert clinical educator supervise you. So if that's piqued your interest, then you're interested to find out more, email m.smith5@uq.edu.au, or probably the first step to do is scan that QR code, and it'll take you to a website, and you'll get all the information there, and you'll get contact emails there as well. You can also contact me, because I'm not going to disappear off the face of the earth anytime soon. Well, not planning to. Okay, so that's the program. Now, what I'd like to do, the master's program, what I'd like to do now is just spend a couple of minutes just talking about the webinar, how it runs, some of the logistics of it. So basically, the schedule highlights are, and I'm quite aware that most of you are here to listen to Rana and not me, so I'm going to get there pretty quickly. It's short. So Professor Rana Hinman will do the Gwen oration as our keynote, and then and that'll be in this room, and then we'll break out into 2 Zoom rooms, and the 2 Zoom rooms, I'm not too sure if those numbers are right, but the email that you got down the bottom, you'll have room 1, room 2. Hit the link to go to the other room if you're not staying in this room, and vice versa if you want to come back. We do keep to time, fingers crossed, no technical hitches, and so you should be able to cross between without missing anything. So we'll have the Gwen oration for an hour, 5:15, 6:15. We'll have a bit of a break so people can organise which room they want to go to. We can stand up, have a small stretch, and then we've got an hour and a half of some quite interesting presentations from our master's students. And to level off the 2 rooms, Prue Butler volunteered as one of our PhD candidates to talk about her very interesting topic, and we'll get to that if you're in this room later on. So thanks to Prue for volunteering to do that. Some very interesting work that pertains to persistent pain, I think, and management. The Gwen oration kicks off our end of semester conference. It has done so ever since we've started a regular end of semester conference in this program, in this new iteration of the program, and some of the iterations prior to us switching over. And we thought it was just a fantastic way, an appropriate way to recognise and acknowledge Gwen's leadership in establishing the master's program here all those years ago. And she directed it and managed it until she retired recently. She's now an emeritus professor in physiotherapy here at the University of Queensland, and she still comes in and does some classes with our students, and for which our students are very happy about. It's pretty hard to live up to her reputation for the rest of us staff. It's really great that she still has such an active engagement. She is, as you'd know, she's a specialist musculoskeletal physiotherapist, and you may not know, an officer of the Order of Australia for her distinguished service of a high degree to Australia. Her research, teaching and clinical interests are in the field of cervical spine disorders. Research has involved quantifying the changes in the articular, neuromuscular and sensory motor systems with neck pain and implications for assessment and management. Although she's retired, she still continues an interest in research, has over 300 publications, authored 3 very popular textbooks, the recent one, 2019, Management of Neck Pain Disorders, a research-informed approach. Over her career, she has delivered over 100 keynote or invited addresses at international and national conferences and has taught extensively in the area of assessment and management of cervical musculoskeletal disorders. She also is still the co-editor of the International Journal of Musculoskeletal Science and Practice. I'd like to acknowledge Gwen as being one of my undergraduate teachers and probably had the greatest influence in me undertaking my musculoskeletal master's program. Well, it was a graduate diploma in manual therapy when I did it over at Curtin. And I have to acknowledge that she was a great supporter and a mentor for me and a supporter in my early days as an academic. So thank you very much for that, Gwen. Now, for the real part of the show. Our keynote tonight is Rana Hinman. Rana is a physiotherapist and a professor and NHMRC Investigator Leadership Level 2 Fellow at the University of Melbourne. Now, for those of you that aren't into the research groove, those fellowships are as rare as hen's teeth, are only given to the really top researchers in our field. So it is a very prestigious fellowship to have, and it's very competitive. She's also a deputy director alongside Kim Bennell for the Centre for Health, Exercise and Sports Medicine. She has over 20 years research and clinical trials expertise in musculoskeletal pain, particularly non-drug treatments for OA. She's experienced in design and evaluation of telehealth and digital healthcare approaches to increase access to care, including telephone, video consultations, internet-delivered and app programs. And that's been more and more feature of the landscape since COVID sped all those things up. I've had first-hand experience of working with Rana in some centres of research excellence and through our program grant in the NHMRC over the last 5, 10, maybe a little bit longer. And I've always appreciated her ability in this area and her expertise. Very insightful and very, it's quite understandable why she gets awarded the high level fellowships. And I was pretty excited and happy when she accepted our invitation to do this. So, and she's going to talk to us about exercise and physical activity for people with hip and knee osteoarthritis. Now, what we need to do is I need to stop share and then invite.
I'll start sharing.
Good on you, mate.
And I'll just flip it over. So I'm hoping you can see the presentation mode.
It's exactly what we can see. And
great.
It's all yours now, Rana. Thank you very much.
Thanks, Bill. And thank you very much for the very kind words and also for the invitation to give the Gwen Jull oration. They're very big shoes to fill. And I'd also like to pay my respects to Aboriginal elders, past, present and emerging. And I'm coming to you all from the lands of the Wurundjeri people down here in Melbourne. As Bill said, I'm going to talk to you this evening about exercise and physical activity for people with hip and knee osteoarthritis. They're my disclosures, and what I've decided to do for tonight is really structure this talk around some key clinical messages that I think, if I was to sit here and say, what are the key messages that a physio or a clinician working with someone with osteoarthritis, and in particular with exercise, should understand, and what do I hope you take away from tonight? These are the 10 messages I'm hoping to tackle over the next 45 minutes or so before we have some time for questions. So let's get stuck into it. I'm not going to spend too much time on osteoarthritis because I'm hoping most people in this audience will be familiar that it is one of the most common chronic diseases in the world, and it's certainly the most common chronic joint disease in Australia. And this infographic's got quite a few, you know, random facts and figures here. But it's really worth pointing out that 1 in 8 Australians are affected by osteoarthritis, and that people with OA are over 4 times more likely to report very severe pain compared to those who don't have OA. OA puts a really high burden on our health system, and this is largely driven through the really expensive joint replacement surgeries that happen for knees and hips every year. And, you know, that the data that you see in this infographic is fairly, you know, is old. It's showing $2 billion back in 2016 from joint replacements. But, you know, we're just seeing increasing numbers of joint replacements happening year on year. So it really is a really high burden condition, and it's common. And I think it's something that really any physiotherapist in musculoskeletal practice will encounter and probably encounter really frequently. As everybody knows, it's really a complex psychosocial disorder. You know, old school thinking around OA was that it was a disease of cartilage and bones, and we certainly know that there is biological damage within the joint. But we also know that those biological impairments extend to muscle dysfunction, altered biomechanics. There's an inflammatory process that takes place. There's somatosensory abnormalities, and all of these interact with a whole range of psychological impairments as well, that really we're probably only still beginning to understand the extent and depth of these psychological impairments that include stress and anxiety, poor coping, reduced self-efficacy, and that feeling of being able to control people's health because of their arthritis. And this all interplays as well with a range of socioeconomic factors. So it really is a complex condition. And because of its complexity, it manifests really differently in one individual to another. And something I think that we probably are really only starting to appreciate more and more is that it's not just the osteoarthritis that we're often grappling with as clinicians, but most people with OA have got at least one other chronic comorbid medical condition at the same time. And we know that in people with OA, things such as hypertension, high cholesterol, back pain, which is really relevant to this audience, and I think depression as well is really worth noting. They're really common. And in fact, multimorbidity is really frequent. So about a quarter of people actually have 3 or more comorbidities. And so that really adds a whole lot of complexity and other factors to be considering when we're managing people with OA, and particularly when we're thinking about exercise. Now, there's lots of clinical guidelines out there to help guide clinicians. I've just put up the Australian clinical guidelines that were last updated in 2018 from the RACGP. All the guidelines are really consistent. So it doesn't matter whether you look at Australian guidelines or look at ones from America or ones from the UK or Europe. All guidelines recommend as core management for hip and knee osteoarthritis education, exercise, and weight loss if it's required. And obviously, we're here tonight to talk about that exercise aspect of care. And why is exercise recommended? Well, it's because we know that it's effective for osteoarthritis. There's a whole range of different benefits, but the ones that are most consistently measured and the outcomes that matter the most to consumers with osteoarthritis are the improvements in pain and improvements in physical function that happen with exercise. But they're not the only benefits that have been observed in research. We also know that exercise can improve muscle strength and balance, cardiovascular fitness. It can help support weight loss. It's not the answer to weight loss on its own, but certainly has a role in supporting weight loss. We can see improvements in psychological state when patients exercise. And all of these will contribute to the improvements in quality of life that we also know have been well proven in meta-analyses for OA. I'm just going to put up some data to show you. Now, the current Cochrane review is quite a number of years old, but our team and others have recently just updated that, and this is currently under review. This is looking at exercise for knee OA. And what you can see is there are lots of RCTs that have looked at the effects of land-based exercise for knee osteoarthritis. What you're seeing here on this graph are standardized mean differences when we look at land-based exercise compared to either attention control or placebo, that's what you're seeing in the blue, or no treatment, usual care, which is the most common control intervention that we see in clinical trials. And that's what you see there in the orange. And you can see different effect sizes dependent on whether the outcome that's measured is pain or physical function. But what we see are quite reasonably strong effect sizes in the orange there, versus no treatment, usual care, slightly reduced as expected when we compare to attention control or placebo. But generally, on balance, we're seeing, quite moderate, reasonable effect sizes looking at the benefits of land-based exercise for NEOA. And the body of evidence here is really substantial. So what we see here when we did this Cochrane review is a whole bunch of new clinical trials, but the conclusions aren't changing. So plenty of evidence to show compared to no treatment or usual care that exercise works. There's a lot less research in hip osteoarthritis, but certainly this is one of the most updated or most recent systematic reviews and meta-analyses, and we're currently in the process of updating the Cochrane review for hip osteoarthritis, and I don't have that data to show as yet, but what you can see here, we see significant effects of exercise for hip OA, but they are a bit smaller compared to osteoarthritis of the knee. So those effect sizes are ranging from 0.31 to 0.38. So really probably be best considered as small to moderate. We don't really know why exercise seems to be a bit less effective for hip osteoarthritis, but that certainly seems to be the case. Nevertheless, it is effective. And this is why clinical guidelines recommend exercise. Systematic reviews also, this is show that effect sizes of exercise are also fairly consistent with the effect sizes that we see from common drug treatments for osteoarthritis. So for example, here we see the comparison with NSAIDs. We see an effect size of about 0.31 or 0.27 when we're looking at opioid drugs, and the effect size with exercise of 0.45 is actually consistent with that sort of moderate, small to moderate effect, and in fact potentially a little bit larger, and obviously with far fewer harms compared to drug therapy, particularly if we think about opioids. There's a little bit of evidence that also suggests that exercise may reduce the need for joint replacement in the future. Now, this comes from a couple of individual RCTs. We don't have a lot of RCTs that report on this outcome just because of the difficulties and the long-term follow-up that's needed to be able to monitor how many people go on to have joint replacement in the future. But certainly one RCT in hip OA suggests that participation in exercise may reduce the need for joint replacement by about 44% 6 years later. And another trial in knee osteoarthritis suggests that that's by 68% 2 years later. So certainly a little bit of an indication there that it may help. It might not prevent totally over the lifetime need for joint replacement, but it might certainly delay the need for that. So on to key message point 2, and that really is to work with your patient to help choose the best exercise program and monitor that program for them. And this is a busy slide. And so the key message I really want you to take away from this is not what you're seeing in these individual forest plots, which is really showing results of a meta-analysis looking at different types of exercise. So that's what you see over there in the left-hand column, whether it's aerobic, mind-body, which is yoga or Tai Chi. And the columns refer to the different outcome that you might be interested in changing, or it might be your patient's goal. And what we see here is that when the effect size is to the right of that vertical black line, that means it's a beneficial effect of exercise. So if you just focus in that red box along the top, what you see here is that all of these types of exercise are effective for pain or function. Some of them, the width of those confidence intervals is quite wide, and that's because we have quite few clinical trials in those areas. And so that's why I kind of would suggest you don't get too bogged down in going, oh, this exercise is better than that, because there is, as more trials emerge, and we certainly get more trials comparing head to head one exercise versus another. We don't have many of those at the moment, and that's what the field desperately needs. As more of that evidence comes to light, we'll see these effect sizes change a little bit and the confidence intervals change. So the key message here is that different types of exercise are effective, which means that you can work with the patient to choose an exercise that suits their interests, but also their needs and their goals, and on the basis of what you assess to be their main problem. So I always think that's a good message for clinicians to understand, and a good message for patients to understand, because people often have a very fixed idea about what would be effective exercise and what might not be effective exercise. One thing that's real, and another reason why it's really important to work with your patient and think of this individualized approach, is that you really do need to be alert for non-response to exercise and be ready to adjust that exercise program if needed. We really know from clinical trials that somewhere, it can be up to about 50, even though on average, that exercise will be beneficial for people in a clinical trial. If we look at individual response, we can see up to about half of participants in a clinical trial actually potentially not being classified as a responder, as someone who's benefited. And this is just data that I'm presenting here, which is a qualitative study that we did from a recent clinical trial, where we actually deliberately chose people at the end of the 9 months, that an intensive 3-month exercise and physical activity program that they then had to carry on for a further 6 months at home. And we categorized people into responders or non-responders based on whether they'd had improvements in pain and function at both 3 and 9 months. So we're pretty strict about how people got into that responder category versus who got into the non-responder category. And then we interviewed them in a qualitative study to really try and explore why they thought they either benefited or didn't benefit, and what their perceptions and attitudes were, to see if we could really tease out any differences. And that's what these Venn diagrams showing you. So over to the left in the green, this is showing you the themes that came up from the qualitative analysis amongst the responders, whereas over in that red pink side on the right are the themes that came from the non-responders, where in the middle there were some themes that were common to both. And what you really can see here, which I've just highlighted in red, are some of these aspects that really speak to the individual nature of exercise. So if we look at the non-responders, we found that amongst that group that there was a big theme of body weight contributing to their problems and causing some challenges with exercise. This group tended to be the group they reported variable adherence. This was a group of people who were more likely to stop exercise if they had any challenges or barriers that they ran into. And some of those challenges and barriers were often related to their comorbid health conditions. So they talked a lot about their comorbidities, but also it might not be comorbidities. They might have been people who had stressors or life events. So, I can think of a patient who was the primary carer for his wife, who was quite disabled, and he had a lot of challenges in being able to do exercise. Whereas over on one of the key things over on the green side is that the responders were all really, really felt empowered. They were highly adherent. Both groups really found strength gains were empowering, and they really valued individualization. So I think this data helps to really, really show that we need to be alert for non-response and be willing to change our exercise programs to suit the individual. Now, I just touched on overweight and obesity, and overweight and obesity as a comorbidity really do pose challenges to exercise. And this data here is another qualitative study that we did nested in a clinical trial a number of years ago, where we took a group of people with overweight and obesity and NEOA, and we were comparing 2 different exercise programs. One was a pretty straightforward non-weight bearing program of quads exercises with cuff weights. The other was a more complex, perhaps what you might call a neuromotor exercise program in functional weight-bearing exercise positions. And what we found was that these patients really talked about a lot of physical challenges. They really found the weight-bearing exercises to be quite complex for movement, difficulties balancing in single leg stance for a lot of these patients. And things that we really hadn't thought of at all is difficulties around use of cuff weights. And I should mention that we also interviewed the physios, not just the patients here. And this was reiterated with the physio, that just the simple application of cuff weights for people who do have overweight and obesity was really difficult. Straight leg raise exercise exacerbated back pain in this sample of people, and they also reported difficulties from other coexisting health conditions, as well as some psychological challenges. So they held a lot of false beliefs about thinking that exercise would be unsafe and harmful for them, a lot of fear of pain, and reported a lot of mental effort of the weight-bearing exercise program. So it really starts, we really need to be thinking very much of our individual and thinking about how we prescribe exercise, and monitoring, following up to make sure what we might have given in the first session, was there any difficulties, were there challenges, and being really proactive about changing a program as we need to. Third key point is watch your language. We used to think of OA, or, I think probably any clinician who's on the webinar could potentially put up their hand and say they've used the term wear and tear, bone on bone, lack of cartilage, it's due to aging. These are all terms that are really common that we use when talking with patients. We might put up the x-ray and show the osteophytes, the total loss of joint space. This kind of language, these terms, actually have really quite harmful consequences for patients. And it makes patients think that osteoarthritis is a mechanical condition that will only improve with a mechanical solution like surgery. And when we talk about loss of cartilage and bone on bone, it creates fear about the knee joint, that the joint is vulnerable to damage, and that exercise won't be safe. I should avoid walking. I should avoid loading my knee to prevent more damage. So these are terms that we really are moving away from, and they really don't fit with what we understand as a contemporary understanding of osteoarthritis, which really is that there is a repair process going on in the joint. And osteoarthritis, so it's not this passive process that only occurs with aging. And when we use that terminology, it makes people think that it's inevitable, that everybody's going to get it. And there's this timeline effect of, well, what's the point of intervening? Because I'm getting older, I'm just going to get it, and I'm going to need a knee replacement anyway. So we really need to start thinking about how we speak to patients. And we wanted to test this theory recently, and this work's been led by a current PhD student who's just about, or might even just this week have submitted his thesis, Travis Haber, who has explored the effect of how we speak to patients in a hypothetical online RCT, where we recruited over 600 people, a mixed group with and without hip pain. And we gave them a scenario of, well, imagine you've presented to your GP with, relatively with 3 months of hip pain, and you're there for a diagnosis to find out what's causing it. And we randomized people to either receive a more, what I'm going to call a more traditional explanation of you've got hip degeneration, with an explanation that was around wear and tear, versus a label of hip osteoarthritis with a more contemporary explanation around that there's repair processes within the joint and that it affects more than just the hip joint, or a more non-specific label of persistent hip pain with a more non-specific explanation around psychosocial causes of pain. So not too dissimilar to what we might talk about with low back pain, for example. And we wanted to see how these labels and explanations impacted whether people thought that exercise and physical activity would damage this hip problem, and how necessary that they thought surgery would be. And we had a whole range of secondary outcomes as well. What it showed was that the people who had the label of either hip osteoarthritis or persistent hip pain, they felt that exercise would be less damaging and surgery would be less necessary compared to people who saw the label degeneration with an explanation of wear and tear. And in that explanation, we had words such as age, degeneration, bones rubbing on bones. And so this experiment really did prove this hypothesis that language matters. And the way that we explain things really matters to how it influences a person's beliefs and perceptions. We also found that with the hip OA and the persistent hip pain label, that people would be less concerned about their hip problem, that they were more open and felt that care from exercise and sports medicine physicians, physios, for example, would be more helpful, and care from an orthopedic surgeon would be less helpful for their problem compared to the people who had the hip degeneration label. So again, confirming those beliefs and showing that these names and labels might influence patterns of care-seeking behaviour. They might influence who a person actually goes to see. Interestingly, the people who received the persistent hip pain label, although they had all of these beneficial outcomes, if you like, they were the group that were least satisfied with this label and explanation. And we tried to explore that a little bit by getting people to tell us in one word, how did you feel when you got this label? And I apologise for the clarity of these word clouds here, but I think you'll still see the key things here. And so if we look at, there's some common feelings that come up across all the labels, such as concerned, old, worried. This is how people feel when they're told about these conditions. But we also see that a lot more dominant words in the persistent hip pain, such as disappointed, uninformed, confused, annoyed, frustrated, unhappy, suggesting perhaps that there's something's missing from that label of persistent hip pain that they're really dissatisfied with. And Travis has recently been unpacking this in a qualitative study that he's just finished, just finishing writing up that manuscript now to submit, where he worked with people to get them to really tell us, well, what were the bits about this label or explanation you didn't like, and what would you want to see? What did you like about this one versus what didn't you like? So keep your eyes out at some point for that qualitative study. Hopefully that, as I said, that was being submitted probably this week. Now, another thing that I think is really important is that exercise education is just as important as the prescription of the exercises themselves. Now, what I've put up here are a few sort of summary areas. This is from a scoping review we did a number of years ago, looking at all the barriers that people with osteoarthritis experience to performing and participating in exercise. And we use behaviour change theory to sort of synthesize all of these millions of barriers, or what seemed like millions of barriers, into some common behavioural domains, if you like, so that we can think about ways that we can target or action these. And there's a whole lot of barriers around knowledge. So people seem to lack knowledge about osteoarthritis. When they lack knowledge in actually how to do the exercises themselves, and knowledge about the benefits of exercise, these are barriers to them actually adhering or participating. Then there's all of these misperceptions or beliefs. So people with OA have all of these, don't believe that a person with osteoarthritis is capable to exercise. So there's these beliefs that symptoms influence capability, and that because I've got knee pain, it means I can't exercise and I shouldn't, and exercise would be bad. An inability, again, we're seeing this thread of excess weight and comorbidities, that there's a perceived inability or not being capable to exercise because of body weight or these other health conditions. And we know that there's pretty much not a health condition, I think, where we can't navigate that and still help a person exercise effectively. And then there's these false beliefs about consequences. Beliefs that exercise is not effective for OA, or in fact it's going to be harmful. It's going to make my pain worse, it's going to make my joint worse. So these are things that we can combat with education, and I think it's really, the onus is really on the clinician to tackle this stuff up front, and really work with the patient to overcome these misperceptions. And we've probably all seen these myths, heard them. Pain in OA is from worn down cartilage. Well, no, it's not, because there's no nerves in cartilage. Pain can arise from many joint tissues and can in fact be exacerbated by a whole lot of psychological factors such as mood, stress, and poor sleep. Exercise will cause more OA damage in my joint. No, it won't. Research shows us this is not the case. And in fact, that we know that loading cartilage is actually beneficial and can actually help reduce symptoms. Pain will only get worse over time. Well, no, it won't. Most people will not get worse. I'm going to show you some data in a moment. Rather, the more natural history of OA is this sort of cyclical nature of some flares. You'll have a period of time where things get worse and then they'll get better. And so, but we've got to challenge these assumptions. Joint replacement surgery is necessary, inevitable. My neighbour had it. I'm going to need it. Well, that's not true. Most people will not need joint replacement surgery. And in fact, there's a number of people who've had joint replacement surgery who are actually not happy with their outcomes. So this is all really important myth busting that we need to do. And this is the data that I just wanted to show you, because I think it's really quite powerful. And I think sometimes clinicians need to see it as well as we obviously need to be able to explain it to patients ourselves. So this is a whole bunch of patients in knees who had radiographic or X-ray changes at baseline. They're followed up over, you can see here, 72 months. And really the moral of the story, there's a small proportion who had severe pain at the beginning in that yellow, and they didn't really change. But what you can see here is that we've got about 70% or more than 70% who never have anything more than mild or low to moderate pain, ever. And there's little change in this pain severity over time, over this, from when we separate these people or look at the cohort altogether. Only 11% of the cohort actually went on to have total knee replacement. And there's a number of modifiable factors that are associated with pain severity that we can modify, which therefore means we can intervene with to change the course of pain. And these include body mass index, depression, and comorbidities. So I'm banging on a bit about comorbidities, but I think it's something that's really important. So tip 4, exercise is safe with OA. People think, is it harmful to cartilage? Molecular biomarkers, maybe I'm going to need an X-ray or it's going to change my joint structure. What about, is it going to increase pain? Well, in fact, most of the research evidence shows that that's not true, as I've already said. We know that there's some mild adverse events with exercise, but these are the typical expected side effects that we see with exercise, such as muscle soreness, temporary mild increases in joint pain that settle quite quickly. People often ask questions about running or loading, and there's been a number of systematic reviews and meta-analyses, and generally the evidence, so this is one from 2017 that really showed a real mixed bag of evidence. Moderate to low quality evidence showing either no relationship between running and osteoarthritis diagnosis or need for surgery, and sometimes some conflicting data. And in fact, I think they found one study that showed running may be protective against the need for knee surgery. So really the conclusion of this systematic review was that we really need more evidence from other studies. A more recent systematic review looked at the effect of running, so using this as an indicator of load, so to speak, on cartilage specifically. And what this really found was that really, if we put aside the people with pre-existing, there's some conflicting evidence in people with pre-existing cartilage lesions, but effectively the evidence is suggesting that running doesn't lead to new lesions. So generally speaking, at the moment, there's not a lot of clear evidence that running will be harmful for people with osteoarthritis. I'm leaving aside elite athletes here because we don't have enough evidence there, and there is there might be a slightly small elevated risk in people who are elite athletes, but generally not a lot of evidence to really link any harms between repeated load-bearing running bouts and harms for osteoarthritis. I'm just going to briefly touch on this because it's a question that clinicians often have, which is what dosage should we be giving for exercise? And really the best port of call, I would say, is to follow the American College of Sports Medicine guidelines for dosage. There's a little bit of evidence that's come from 2 systematic reviews that I've put on the screen here. which is that when exercise is prescribed according to these dosage guidelines, that the exercise may be more effective for increasing strength in knee osteoarthritis or for being more effective on symptoms in hip OA. Now, we'll just call your attention to the fact that these systematic reviews are a number of years old now, and there's actually increasing evidence suggesting dosage perhaps doesn't matter. We're not being able to find increasing RC meta-analyses are showing no relationship between dosage parameters and symptomatic outcomes from exercise in OA. But it's a good rule of thumb, I think, to follow these guidelines. And I'll pop these up here, you know, for strength exercise, that we'd really be looking at a frequency of at least 2 days a week, 1 to 3 sets of about 8 to 12 repetitions, making sure that exercise, you know, that the intensity is appropriate, bearing in mind that it needs to be a little bit lower for really beginner, novice or older exercises. And as people progress, really trying to increase that intensity. So there's nothing new here for physios. Similarly, their guidelines for aerobic exercise are at least 3 days a week. And again, making sure that that intensity is at a moderate or vigorous level. Let's talk about adherence. It's really, I think, we used to see adherence as being a patient problem. We've given them the exercise, we've told them what they need to do, and they just won't do it. I think it really is important. It's a two-way street. Clinicians really need to help people adhere to exercise. And this is because we know that adherence is problematic, and we know that adherence declines over time. So this is some work from a prior PhD student of ours, Pip Nicholson, from a number of years ago. She combined 3 of our clinical trial cohorts of people with knee OA who'd done home exercise programs as part of their trial interventions. And they self-reported their exercise adherence on an NRS across all of these trials, so we could pool them together. And what you see in this slide is really just how exercise adherence declines. People, on average, you know, reasonably adherent at the beginning, and then it just declines over time. And what she was able to show with the latent class analysis here is that most people belong to 3 subsets, if you like. There's this group of people who are pretty adherent at the get-go. So if you look at the left-hand side, but then their adherence gradually declines over time. Then in the middle, we've got this group who start off pretty adherent. You can see a score of around 8 out of 10, so that's pretty good. But then their adherence drops off pretty quick and really bottoms out fairly quickly. And then on the right, we've got this really problematic group who are poorly adherent from the beginning and remain poorly adherent the whole way. Ideally, we'd like to be able to identify these people from the get-go. We tried to do that to see if there were any characteristics that could separate these groups, and we really couldn't find any really, I would say, clinically meaningful characteristics. There was a signal that in that rapidly declining adherence group, that this was a group of people who had more mild symptoms at the beginning. So they had lower WOMAC pain and better function compared to that gradually declining group. So maybe their symptoms weren't severe enough, or perhaps their symptoms improved fairly quickly if we think about that fluctuating nature of OA, and that might explain why their adherence dropped off. With the low adherence group, there was a suggestion that these people may have had poorer self-efficacy compared to the rapidly declining group. So maybe they just didn't feel like they feel confident in their ability to do exercise, and that exercise would help their symptoms, and that might have explained why they weren't very adherent at all. So we really need to discuss adherence from the outset. We need to monitor it, and we need to work with the patient to identify those barriers or challenges and help them to troubleshoot solutions and adjust the exercise program. There's no point persisting with something that a patient can't do or won't do. We need to find alternatives. This was the scoping review I alluded to a little bit earlier, and this is just an adapted checklist that we kind of adapted and have developed based on what we know from barriers to exercise, with some, you know, it's really just a suggested questions, if you like. It hasn't been validated. It has face validity based on the scoping review we did, but these are some simple questions that you can ask in a clinical setting that might, you know, answers to these might, a yes answer might trigger some red flags in your head thinking, okay, this is a person that might have problems with adherence. And we might need to think about, troubleshooting this now, or giving, me thinking about how I might change the program and perhaps monitoring a little bit closer. So you might want to think about some of these questions that might trigger some action on your part as a clinician. It's really hard to monitor exercise adherence, and researchers' best efforts are really still struggling to come up with a very valid and reliable measure of adherence. And so really, at this point, I'd say use your clinical judgment to the best approach. Ask the patient, have a conversation. In our research, we use logbooks or calendars to getting patients to record exercise sessions. We don't do it over 9 months. We will get them to perhaps record it for a week, snapshot over a month. You can use wearables if what you're doing is measuring steps or physical activity. You can use mobile apps. We've developed a mobile app that's free called My Exercise Messages that allows people to log in and graph their exercise sessions, and it provides messages asking them about barriers and challenges to overcome their exercise. And I'll provide a QR code for that at the end. So there's lots of different ways, but just making sure that it is something that's on your radar and that you monitor. Advise people to increase their physical activity levels. This is probably something that I think physios have tended to focus a lot on prescription of a therapeutic exercise program, so often a strengthening program, but we often have neglected physical activity levels. And we know, we could go, well, most people don't do enough physical activity, and yes, that's true. We know that also in people with hip and knee OA, only about half are getting more than 7,000 daily steps, and less than half are performing what's considered, recommendations of 150 minutes of moderate to vigorous activities, which is what's recommended for good health. Really alarmingly, adults with knee OA spend 2/3 of their daily time sedentary. One thing that I don't think is helpful for people with OA is giving them really lofty physical activity goals that are just overwhelming, and people go, I'm never going to be able to do that. And so sometimes I think that 150 minutes of moderate to vigorous activity a week, or that belief that 10,000 steps a day is what's needed. We've now got some research showing that, more achievable goals will actually result in meaningful benefits for people with OA. So if people can do 6,000 steps a day, we've got research that shows that will protect against future development of functional limitation. And every additional 1,000 steps, so small extra bits, will further reduce that risk by 16 to 18%. And there's now research showing that just 45 minutes of moderate to vigorous activity is predictive of improved or sustained high levels of physical function. So I think we need to use this evidence when we're educating patients and setting activity goals, to set goals that are achievable and give people hope that doing this sort of activity and becoming more active will actually benefit them and their future physical function. Use technology to help support exercise management. There's lots of ways we can use technology. I've put a few examples here on the slide, and I'm not going to be able to go into this in much detail because that would be another 2 hours on its own. But I would point you to this really nice review at the bottom there that was published in 2022 that really summarises, obviously at that time point, this how you can use technology to help with people with OA. We've focused a lot on the use of telehealth as the mode of delivery for exercise practitioner consults. And there is increasing evidence from clinical trials that delivering exercise-based care using telehealth is effective and acceptable, and that can be via video conferencing or telephone delivered care. And so we've had published a number of trials. This first one was back in 2017, where we used Skype. Does everyone remember Skype? For delivering video consults. We've looked at telephone delivered care in people with knee OA. Fairly recently, we worked with Medibank to design deliberately telehealth delivered programs using Zoom, looking at exercise and weight loss for Medibank members. And based on the effectiveness of those programs, Medibank has actually rolled this out for their eligible Medibank members. And most recently, we've just published a non-inferiority trial that has compared Zoom consults with a physio head-to-head with in-person consults for delivering exercise, physical activity and education. And it showed that tele-rehab via Zoom was non-inferior. So I'd encourage you to look at those trials. We've produced a whole range of digital resources and tools that I know there's a lot of QR codes here, but I think this session is being recorded, so you can either take a photo of the screen or get back into the recording to come and have a look at some of these resources, whether they're e-learning courses for clinicians or patients. That's what taking control of OA is at the bottom, to the mobile app I talked about, to self-directed exercise programs online that go direct to patients with OA. Now, the last point is kind of the elephant in the room, and this is probably might be the key message that maybe all of you might hate. It's often the thing that physios are most uncomfortable with, and it's that we don't actually know how exercise works. And in fact, actually, if we think about what we do know, it's not really working the way we think it is. This is just a slide that people may have seen before, when if we think about any intervention, doesn't matter which one, whether it's exercise or, you know, a drug treatment, for example, and anytime, you know, we see a patient and we give them treatment A, and then they come back, you know, a couple of months later and they go, yes, I'm better. That improvement in pain can be due to any number of things here. It can be due to the component in that grey box, which is the direct treatment effect, sometimes called the specific effect of the exercise. So if we're talking about a treatment, it might be exercise. So it could be because their muscles got stronger, for example. There's also a component that we know is the placebo effect. So that's when people get better because they expect to get better from that treatment. There's also then a bunch of other reasons why people can get better, and that's natural history. We've already talked about that, how the natural history will be one that fluctuates. Patients often come and see us or enroll in my trials when their pain is at its worst. So the next change in state will naturally be an improvement. People are usually taking other co-interventions at the same time, whether they're seeing you or they're enrolled in my trial. So there will be those other things. There's also the fact that they're seeing a clinician and someone's taking interest and caring about them. So all of these together are the contextual effects. What do we know about the only way we can really tease all of these factors out is to really have a 3-arm trial where we compare the active treatment to a placebo treatment to a no treatment group. And this is just some data that's taken from a Cochrane review. It was a meta-analysis, further analysis of a big Cochrane review that looks in all clinical conditions, and they took 3-arm trials like this, where there was an active treatment, a placebo, a no treatment. And what they showed is that over half of all treatment effects, it doesn't matter what treatment, what health condition, they're due to contextual effects. So we know that contextual effects have a big impact. And they certainly have a big impact in OA, and certainly bigger than what we see in what I just presented to you in that slide. This is data from a meta-analysis from nearly 10 years ago. You can see it's got topical NSAIDs, chondroitin, hyaluronic acid injections, acupuncture, pulsed electromagnetic field. That is hyaluronic glucosamine and chondroitin again. Corticosteroid injections is what IACS is. What we're seeing here in the blue is the contextual effect versus the specific effect. So in something like topical NSAIDs, 85% of the effects are due to contextual effects. And on balance overall, what we're seeing here in OA is that 75% of treatment effects appear to be contextual. What about OA? One of the problems we have in the OA field is that we don't have many placebo-controlled trials. We certainly don't have many 3-arm trials. This is some data from the recent DISCO trial that was done over in Copenhagen, where they compared the GLAD exercise program. Many of you are probably familiar with GLAD, to a series of saline injections over time. And what they showed was that and bearing in mind that saline injections are considered inert, and and what they showed is that basically exercise and education was equivalent to inert saline injections. And many critics of the trial go, oh yes, but this is because they only had short-term follow-up. Maybe after 12 weeks, longer follow-up, we'd see benefits of exercise. Well, they followed them up out to 1 year, and there was no difference between exercise, education, and inert saline. So it's really showing that there's small benefits that are not really meeting, or not at all meeting, any clinically relevant magnitude, or any magnitude of difference that we would consider meaningful. Some may say, well, perhaps the GLAD program is not intensive enough. So then we have the START trial that came from the US a couple of years ago, published in JAMA. This one looked at 18 months of high intensity versus low intensity exercise training compared to an attention control. And what this trial showed was that high intensity strength training did not reduce knee pain any more than an attention control group. So we're certainly seeing here that a lot of the effects of exercise, there's no disputing that exercise has quite powerful effects compared to no exercise or usual care, but certainly a large proportion of those effects do seem to be contextual. We're starting to unpack the direct effects of exercise a little bit more, but there's a lot of work to be done in this space, because very few clinical trials actually explore within the trial what mechanism might underpin or explain the change in pain that's observed with exercise in that trial. That requires quite a complex mediation analysis, but it also requires you to measure those things that you think might explain changes in pain. And there is some evidence, sometimes inconsistent, from individual RCTs that improvements in quadriceps strength may help it explain the change in pain. But also what we're starting to see is that there's a lot of that cognitive and psychological factors seem to be really important. Improvements in arthritis self-efficacy, reduced fear of movement, and changes in pain beliefs are also coming up as really important factors with explaining why people have improved pain. And in fact, they may be stronger than changes in quadriceps strength, because a recent individual patient data mediation analysis showed that change in strength was the only significant factor that explained improvements in pain, but it only explained 2.3%. So 98% of the mechanism was unexplained. So to finish off, I hope I've left you with some food for thought and some key clinical messages. I'll just put out a shout out just to, if you're interested in any of, only sort of touched on a bunch of the research that we've done down in Chesham, but I'd point you to our website. We try and keep that up to date, and we have quite a lot of patient clinician resources all freely available there. And you can sign up to join our knowledge translation network, where we send out newsletters sort of sharing research updates and all sorts of other things over the course of the year. So I'll stop there, Bill, and throw to you.
Oh, that was excellent, Rana. That's you've condensed quite a bit of work into 45 minutes or so. I could almost feel the tension of what you had to leave out. Thanks very much. That was very very insightful and very helpful, having it structured around the 10 points. We've got 13 questions. If you hit the Q&A box,
I'm just going to stop sharing so I can see the Q&A box.
Andrew Hislop asks, I'm interested in measures of balance and or falls risk in people with knee osteoarthritis, and where research is going next in management exercise recommendations to improve balance, reduce risk of falls, role of comorbidities and coexisting mask conditions in the balance and falls risk space.
Okay, which question are you looking at there?
So
that's not the top one, is it?
No, if you go to that little arrow at the top right, it says most recent. Just hit that and you get most upvotes.
Okay, yep, sorry. Yep, most upvotes. Okay, yes, all right.
I just discovered that.
Yep, okay, thank you. That's new for me. There are, okay, I can't talk to, there's a lot of work really on looking at falls risk measures in OA. There has been some work looking at balance measures. And they're okay. So we tend to use, we've used in our research experience, things like the step test, there's the 4-square test. I'm just trying to think if I can point you to a paper that really suggests anything. There's no one measure that comes off the top of my head that is recommended, because balance is something that is really probably being neglected in the OA space. It's beginning to be recognised only because we're starting to understand from big data sets that falls risk, or there's an increased risk of falls, which is a problem. So the types of exercise, and there's some types of exercise which lend themselves better to falls risk that have evaluated changes in balance. And so that's stuff like yoga and Tai Chi. So if you're looking at, sort of what types of exercise might be beneficial there, I'd encourage you to look at that research. Role of comorbidities, nobody has really looked at how do comorbidities interact with falls risk, but I do think I read some research that the more comorbidities that you have, I think it's probably consistent with others that you are potentially more likely to be at higher risk. So it is an important area.
Excellent. If you hit that circle with an arrow, you'll get Julie Harrison asking a question on aquatic.
Is that the one? Is there any evidence that aquatic exercise is as beneficial as land exercise? Yes. Okay. In short answer, I can only think of about 1 or 2 clinical trials, and they're quite old, that have ever even had multiple arms. So in answer to your question, no one has really compared land-based versus aquatic head-to-head, which is why those systematic reviews usually analyze that data separately. We know aquatic exercise is also effective from the Cochrane review. So I would say, and similar to what I would say with the type of exercise, I would say I'd be working with my patient to find out who wants to do what, and work with them to make that program, to prescribe a program that suits them. Because you're exactly right, there are some patients who really like water exercise. On the flip side, there's some that really hate it. And so it's something that you'd want to have a discussion with. But I also agree that water exercise can be a really nice transition, because we need to switch up exercise programs for patients. They get boring. They need to progress and change. So maybe we start with land-based and then move to aquatic when we need to. Okay.
Kieran's next.
Yep. Ortho screening role. Who may progress to arthroplasty in those who come to us with radiographic OA? In short answer, no, we don't have much insight at all about who's going to progress with that. I mean, I do think there's increasing evidence that psychological factors will play a role. So I suspect if you see people with more comorbidities, more psychosocial challenges, I would suggest they could potentially also be someone who may progress quickly. But it really, from an individual point of view, it's going to depend on the patient and their surgeon and the patient's experiences. There are some people who are just determined. They've seen their neighbour do so well from surgery. It doesn't matter what any clinician says. So I think there are things to think about. Tim, is that the one you want me to go to next, Bill? Yep. Picked up unhelpful. Yes. Unhelpful beliefs from other health professionals. That is a really, really powerful message. We know, and we did, I presented to you that online experiment we did with Travis's one where we changed the labels. We also did one where the GP recommended you have exercise, and that was the most powerful thing. So if you can work with GPs and health professionals who give the recommendations that you want, that will be a really powerful facilitator. But it is really unhelpful when those respected, authoritative professionals have given advice that's to the contrary. I don't have any magic solutions for how you deal with that. I'm a researcher. I would always rely and use data and evidence to help my case when explaining to patients, obviously not just throwing a forest plot in front of them or saying, read this paper, but using the data and the research evidence to back up what I'm saying. Because, but ultimately, at the end of the day, the patient will decide, you know, they're taking information in from lots of sources. We've talked about the neighbour, their partner, their daughter, their doctor, and you. They're going to filter and decide and weigh up whose information resonates with their beliefs as well.
We'll do one. Shane McNamara is next on the list.
Educated in the differences in helpful or good pain or unhelpful. No, I can't think. I mean, what you're asking there, is there any clinical trials that would show this? No, I can't. Anything that we'd be talking about here is really based on theory and what we're extrapolating from sort of qualitative research. So no, I can't think of any experimental study that's actually looked at manipulating this. But I think this is really where the OA field is going. I think you're going to start to see more of this research coming out. Recently, in the 30-year anniversary of the osteoarthritis and cartilage journal, there was a opinion piece all about changing the narrative around osteoarthritis, and really basically a call to action for the whole clinical research community. So I'm hopeful we'll see more research for that in future. Pat,
I think we might wrap it up there. Yep. I think in the interest of just making sure we don't run late. If you have time, you could type some answers for these questions.
How about I do that? Yep.
Yeah, that'd be great, Rana. Thank you very much again for accepting to do that and for delivering an excellent keynote. It was right on the money and very useful to the people that turned up, I'm quite confident. So thank you very much for that. Well, welcome back, everyone. It's 6:30, so we better get this show on the road so we don't run late. Our first speaker is Kristen Niels, talking on sleep disturbance and neck pain, a physio's quandary. Now, she's one of our Master of Physiotherapy Studies graduates from 2014 and is a long-term University of Queensland supporter with 2 other degrees to her name. Kristen has worked solely in private practice where clinical workload has included primarily musculoskeletal caseload and the delivery of one-on-one and small group supervised exercise sessions that include gym and Pilates-based rehab. This path has led her to become involved in Pilates teaching training, and she has been part of the education team for Polestar Pilates Australia since 2021. She thoroughly enjoys both teaching and learning, undertaking many professional development courses and eventually leading to the current program, which she's about to finish. Outside of being a busy physio, she enjoys going for walks with a Spoodle Gus and playing golf. Now, I asked all the students to tell us why they choose the topic, and the reason she's chosen this topic is because she often sees patients with neck pain and is aware of the importance of sleep for management and recovery of musculoskeletal pain. So was keen to learn more about this relationship and the role a physio can play in identifying disturbed sleep and management pathways. So without further ado, I'm going to hand it over to you. Kristen, take it away.
All right. Hi, everyone. So thanks, Bill, for the introduction. So I'm presenting on sleep disturbance and neck pain, a physiotherapist's quandary. I guess really this is a bit of a dilemma. So the first dilemma was, where do we start? Is it the chicken or is it the egg? Why is it important to understand this relationship? And what can we do as physios to help address this? So I think there's probably a generalized understanding that there is this bidirectional relationship between disturbed sleep and neck pain, and that both of these, I guess, symptoms on their own are very multifactorial in nature. So there are probably several things interacting that affect both of these things individually, but then how do they work together? So for today, neck pain, I'm focusing on mainly sort of mechanical and chronic neck pain. So I won't be talking about whiplash or neck pain with radicular symptoms or radiculopathy. And also, I think a lot of the research does really focus on pain, which is understandable. But I guess, from what I've learned about this relationship with disturbed sleep, should we also be equally focusing on sleep in certain circumstances? So disturbed sleep is really, so we're talking about the decreased quality and or quantity of sleep. So non-rapid eye movement versus rapid eye movement sleep, deprived sleep, and also insomnia. When we look at disturbed sleep in healthy populations, so there are a couple of meta-analyses by Shrimp and colleagues 2015 and Chang et al. 2022 that have looked at the effect of disturbed sleep in healthy populations. And they both show a sort of medium/moderate effect size for the effect of disturbed sleep on pain perception and also pain threshold in people that are otherwise healthy and don't currently experience any musculoskeletal pain. I guess with a lot of these studies, though, they do tend to deprive sleep over 1 or 2 nights. So it's not a long time, and it's usually conducted in a laboratory setting. So, in terms of how we can extrapolate that into people when they're sleeping at home over longer periods of time, some of that is a little bit unknown. But I guess there was this one study that I found by Yabe and colleagues in 2022. That was a 3-year longitudinal study with over 2,000 participants. And they sort of monitored people that didn't have neck pain with disturbed sleep, and I guess whether or not they then developed this neck pain. So they actually found that, so the odds of, if you had disturbed sleep for less than a year, the odds ratio was 1.86 with a standard deviation of 1.08 to 3.2 for developing neck pain. And then once we got to having disturbed sleep for more than 2 years, that odds ratio went up to 3, but there was a wider standard deviation for that, so 1.94 to 4.65. But I guess, it just shows that even if you don't have pain at the start, if you only have disturbed sleep, then your odds of getting neck pain increase the longer that disturbed sleep stays around. If we look at then the, neck pain and what happens with people with neck pain and disturbed sleep. So one of the studies by Aldebars et al. 2022, they did a convenience sample of 376 people with neck pain, and 62.3 of those people reported that they had sleep disturbance. They also did a study that was published the year before in 2021, where they used polysomnography to assess sleep in people that had chronic neck pain. And then they found that there are alterations in sleep quality, so increased latency to sleep onset and also increased latency to REM sleep onset. So great that they use polysomnography and they assessed people with neck pain, but they did only have a small sample size, and this was only males. So we don't really know, what the sleep is like in females with chronic neck pain. So there is also a negative relationship between sleep quality and pain. So as sleep quality goes down, pain goes up, and then conversely, we get the flip side that if sleep quality improves, then pain usually also improves. Kovacs and colleagues in 2015 also demonstrated that there is poor prognosis with disturbed sleep in people with neck pain. So if disturbed sleep is present, people are less likely to improve. This was at 3 months, so the study only went for 3 months, so we're not sure about the longer term implications of that. And finally, there is an increased rate of transition from acute to chronic pain with disturbed sleep, which we'll go into a little bit more. So this study by General and colleagues in 2017, it was a longitudinal study conducted over 6 years. And they really looked at people if they had acute neck pain. So what was the rate of onset to chronic neck pain? And they found in those that had insomnia, there was a hazard ratio of 1.6. And in short sleep duration, there was a hazard ratio of 1.52. So from what we've had a look at so far, not only are people with disturbed sleep have increased odds of developing neck pain, if they have disturbed sleep when they have an acute episode of neck pain, the rate of transition to chronic neck pain is also higher. Yes, as I mentioned at the start, sleep disturbance and neck pain, there are a lot of other factors that can, mediate this relationship. So, psychological status is probably a big one. So particularly depressive symptoms and anxiety. Interestingly, that study that I mentioned before, so Humeral et al. 2017, their population also were people that had depressive symptoms, but they actually found that the depressive symptoms only partially mediated the association with insomnia and pain, and it didn't mediate at all the relationship between short sleep duration and pain. So that's, I guess, a little bit interesting there. Genetics and other health conditions. So Andriucci and colleagues 2020. So this was a twin study. So they actually compared they sort of grouped everyone together. So those that had neck pain and those that didn't, both as separate groups, and then also each as their own individual case control analysis. And they also did find a significant association between sleep disturbance and chronic neck pain. But this was only in the dizygotic twins, so the non-identical twins. They didn't find the association to be significant in monozygotic twins. Other health conditions that could affect sleep, so sleep apnea, respiratory conditions, and any other environmental factors that could be at play at home if they have a partner that snores, any other noise or light. So there's a whole bunch of other things that can interact on this relationship. And then finally, exercise. So exercise there's a bit of a reciprocal relationship as well between exercise and pain, and then exercise and sleep disturbance. So all things we need to, I guess, keep in mind when we're thinking about sleep disturbance and neck pain. So we've spoken about, I guess, the relationship between disturbed sleep and neck pain and disturbed sleep. But how do we assess it? So often when we are, we see a patient, we'll ask them about, how are they sleeping at night? Do they have any night pain? What's their pain like in the morning? But, we often don't go into it in further detail. So, I mean, the Pittsburgh Sleep Quality Index is the most commonly used generic sleep measure, both in clinical and research settings, and it really does just focus on sleep. So there's 24 items, and a higher score indicates poorer sleep quality. So that's a way that we can go a little bit more into detail if we think it's necessary for the patients that we're seeing. All right. So now hopefully we have a better understanding about the relationship between disturbed sleep and neck pain and vice versa, and how complex it is. So I guess what can we do about it? So like a lot of other conditions, when we think about disturbed sleep and neck pain, the evidence really does suggest that multimodal physiotherapy treatment is the way to go. So I'm really focusing on just what we can do as physios. I'm not going into any other management that could be psychological management or pharmacological management. There was actually a review that was published, a systematic review that was published this year by Navarro, Ledesma and colleagues in 2024, and they reviewed physical therapy techniques and also other interventions specifically on sleep. This wasn't specific to neck pain, although they did have some neck pain studies included. That was just chronic musculoskeletal pain. And then they really did suggest that this multimodal approach was the way to go. So we've got sleep posture, exercise, and then how, I guess, those couple of things integrate from a multimodal perspective on pain management. So I guess the one thing that is probably a little bit different that I noticed in terms of looking at sleep disturbance and neck pain is, I guess, looking at sleep posture. So people spend a lot of time in their beds, sometimes in sustained postures. So I guess this is one thing that there's a growing body of research around. So Doug Carey and colleagues in 2021 had a look at sleep posture. They did look at spinal pain, but they split it up into, there was a cervical pain group and then a lumbar a lumbar pain group, and they found that the people that had neck pain actually had more frequent postural changes, and they actually had more time spent in, I guess, undesirable or provocative positions. The nice thing about this study is they use infrared cameras and they actually assess people in their own homes. So they were being assessed in the environment that they usually sleep in, not in a laboratory. So I think that's probably interesting to know. And I didn't find any other studies that actually did assess people in their own homes. That does bring in other variables that can influence findings, but I guess there's always a balance. Another study by Gordon and colleagues in 2007 were looking more at sleep positions and what positions affect waking pain and sleep quality. And really the big thing that came through from that study was to avoid upright sleep positions. So they were associated with increased waking pain and decreased sleep quality. And they recommended side lying and supine positions, and they didn't really find that much difference between the two. So we could potentially be recommending people sleep on their side or on their back. There's also the lovely research around pillows. Okay, so if people are sleeping on their side and on their back, they're most likely sleeping on a pillow. And the general consensus is, it's got to be comfortable. And there's really kind of no real, I guess, consensus on people should have one type of pillow over another, but it's got to be comfortable and it does need to actually support the neck well. So it could be a curved pillow, it could be a feather pillow, it could be a pillow made out of another material, but as long as it supports the neck well and keeps the neck in relatively neutral, then that is shown to be what is most effective at pain. On pain, sorry. They did find something interesting in terms of, so I say that the material doesn't generally matter, but it seemed that, the latex rubber pillows might have been a little bit more favoured than other materials, but the actual shape of the pillow didn't matter so much. What was interesting in terms of, so this article by Pang et al. 2021, it was actually a systematic review and meta-analysis. And they actually found that, with the right pillow, it had positive effects on pain, decreased waking symptoms, decreased neck disability, but it actually didn't have any effect on sleep quality, which I found quite interesting. And most of those studies did use the Pittsburgh Sleep Quality Index to evaluate sleep quality. So, we're improving pain, but we're maybe not affecting sleep quality. Right, next one. And then finally, we have exercise. So there are many studies out there about different types of exercises for neck pain, which I'm not going to go into the specifics of that, but I guess we know from the research that specific neck exercises do have a positive effect on pain. And there's also some effects of general exercise on pain. So a study by Chinui and colleagues in 2015. So they looked at, they reviewed sort of exercise and the effect on the circadian rhythm, the immune inflammatory response and body temperature, and just general exercise can affect those things and therefore have a positive effect on sleep quality. There was a systematic review by Coleman and colleagues in 2023, and that looked specifically at neck exercises and also other exercises for pain. They did recommend that, the exercises needed to include neck extensor work, but most of these studies really looked at, I guess, combining those neck extensor exercises with others. So it's really hard to tease out exactly which exercises are specific to improving pain. But it does seem like that there are a few that we can choose from. So in terms of pain management, so of course there is the review that I mentioned before about Navarro Ledesma and colleagues that was published this year. In addition, other things we could do to address pain management. So we've got obviously our manual therapy, and then we've also got, so what I've just spoken about before in terms of exercise, and what I spoke about right at the start in terms about the relationship between disturbed sleep and neck pain is, I think, a really important part of the education that we provide to our patients. So, and also making sure that we are picking that information up whenever we see our patients. And we can also give them some self-management strategies. So that's going back to, I guess, the sleep posture side of things in terms of pillow recommendations. We might need to look at how people are sleeping with their current pillow at home. Is it comfortable? In terms of seeing other ways that they can help to manage their pain that might then, I guess, influence their sleep quality and then have that sort of circle effect to affect their pain. All right. So in terms of our take-home messages for today, so I've spoken about disturbed sleep and neck pain. So I guess the main things that I would like people to take home is that in people without pain, disturbed sleep decreases the pain threshold and increases your odds of developing pain. There is also an increased rate of transition from acute to chronic pain. And disturbed sleep in those with neck pain is linked with a poorer prognosis. So it's really important for us as physios, I guess, to, address sleep posture, address exercise, and also look at self-management and education around sleep quality and pain management. So back to our chicken or the egg. I think the dilemma still exists. Is one more important than the other? There are a whole lot of other, I guess, avenues that we could go down to further explore that relationship. But I think it's just important that we understand the relationship and that we understand if there are some different factors that are involved that we can employ as physios to, I guess, help people that have neck pain and also experience sleep disturbance. So thank you, everyone.
Thank you very much,
questions?
Kristen. There are 2 questions in the Q&A. If anyone else has any questions, do please put them in there. We'll start. I've got a question or 2 maybe, but some of the ones in here are a lot better than what I could come up with. So I think Al was asking, can you see the questions?
Oh, hang on. I'll do the...
I'll read it out. Thanks for...
Oh, yes. Yep. So I've got
presentation.
the 3. Yep.
Do you know what? And make sure you have most upvotes so you'll find the one that most people want to hear first. Do you know what neck extension exercise were included in the study? What dosage was given?
Oh, so there were a lot of, so it was a systematic review and meta-analyses. So they were grouping the studies together. It was a little bit tricky to figure out exactly which exercises they were specifically given. They pretty much just, I'd have to actually go from the meta-analyses into all of the specific papers that were used in the study to figure out exactly what neck extensor exercises were given. But I guess it's important that we do something that is going to target the neck extensors.
So what exercise would you give?
I guess you'd have to put them in a position where the neck extensors are going to have to work against gravity. So we could do something in like a 4-point kneel position. It really depends on the person's capability. So it could be 4-point kneel, it could be in prone, it could be on forearms. So it just depends if it's an integrated exercise with something else or if we need to target that specifically on its own.
Cool, thanks. Tim Duffy, hey, g'day Tim, thanks for coming along. If our physio interventions aren't effective and patients are still having sleep disturbance, when and who would refer to? When and who would refer to, yep.
Yeah, so I think that comes along that to probably where that Pittsburgh Sleep Quality Index might give you a little bit more insight. So we might not give that to someone on day one, but if we're sort of finding as we go along through our sessions that, you know, the sleep is really a problem, then maybe we could give them that questionnaire, see what their score was. And then it might actually be a referral back to the GP or for psychology referral. There's also some things out there in terms of cognitive behavioral therapy, and then there's also pharmacological management as well. But once we get into the pharmacology, we're getting into things that can potentially have increased side effects. So it'd be Pittsburgh Sleep Quality Index, and then depending on the outcomes of that, back to the GP.
Thanks. So Yoga Physio asks, is anyone looking at sleep disturbance and neck pain in menopause with or without HRT and endocrine dysfunction like Hashimoto's? It's a pretty good question. You might answer that.
Do you want me to answer that now?
Yes, if you could.
Yeah, I actually don't know, because it's a very specific question. And I guess in terms of the realms of a 20-minute presentation, that would possibly be a 20-minute presentation on its own. There is one study that I did find that was looking at sleep disturbance and neck pain and shoulder pain in women. It wasn't specific to menopause and Hashimoto's, but I guess sleep does have, once we get into that sleep cycle, there is some links when we get into sleep about, you know, the immune processes. So that's probably the best I could answer for that.
Are there any other comorbidities that came up when you were doing your research?
Yes, I think, so probably mentioned some of them. So if they have any respiratory conditions, so if they're on a CPAP machine or something like that, and they have trouble breathing, especially if they need to be in that slightly more upright position, which tends to aggravate neck pain from a sleep posture perspective, or if they have also sleep apnea, there's a few different things there.
Mm-hmm. How are we going for time? Probably do one or two more. Our Anton asks, can you please expand on what you mean by pain management strategies? Can you differentiate how this might change from acute to chronic transition?
Yeah, so where I was going in terms of pain management strategies is that from, I guess, what I covered in the presentation was more that the sleep posture and the exercise linking in with other pain management strategies that we might use, such as manual therapy, was, I guess, that closing that loop of pain management. There's also, you know, it goes back to the whole dilemma of the situation, the chicken or the egg. Do we need to manage the pain or do we need to manage the sleep? So which is the driving factor? So there are, you know, once we get into pain management, you can get into your pharmacological management, your conservative management. It really depends what is the driving factor.
Okay, there's a couple of more questions there that I might ask you to answer offline. I'm just very wary. I don't want to update and be on time.
Do I type the answer to that?
Yeah. If you go to Q&A and you can say type answer and then you just go for it. Thank you very much for that, Kristen. You can relax now and enjoy the rest of the evening.
Great, thanks, Phil.
And stop share, and we will make sure that we can get Elang all fired up. Thanks very much, Kristen. So our next speaker is going to be talking about cervical dystonia and what is the role of physiotherapy in it. Now, Elang hails from Singapore, did her Bachelor of Physiotherapy down at the University of Otago, so you probably couldn't think of two quite disparate environments to do it in, one very humid and one very dry and cold, but a nice place. Both places are nice. Elang has worked in public health systems since graduation, and that's been in Singapore at the National University Health System, working in two hospitals, National University Hospital and the Alexandra Hospital, currently based in Musculoskeletal Outpatient Department, has done all the rotations. She tells me that she enjoys brewing and sampling coffee from around the world and recently started getting into bouldering as a hobby. Her interest in the topic began with an encounter of a patient who was diagnosed with cervical dystonia, and it wasn't a condition she was familiar with or was commonly seen in the outpatients department there. It was a challenge trying to manage the patient and family, so interest in this topic springs from that. So she wanted to find out, what role do physios have in assessing, managing patients with this condition. So I think without further ado, Elang, I'll let you tell us all about what you found with cervical dystonia.
Sure. All right. So good evening, everyone, and thank you for the introduction, Bill. My name is Elang, and today I'll be presenting on this topic of cervical dystonia and what role do we play as physiotherapists. So how many of you have had the experience of managing patients with cervical dystonia? Do you feel like you know how to manage them well? Or perhaps like me, have had no idea on the best management when I had to see my first patient with this condition? Perhaps you may think our role in managing this group of patients comes in the form of their motor symptoms, such as abnormal movement patterns, postures, as well as tremors. But there is more to this iceberg, and I will share more through this presentation. So cervical dystonia is a disorder characterized by sustained or intermittent involuntary muscle contractions that lead to twisting movements and abnormal postures. The most frequent manifestation is in regional involvement of an isolated muscle group, with the neck being the most commonly affected area. People with cervical dystonia suffer from overactivity of neck muscles with involuntary turning, tilting, and twisting of the head. A cause is not identifiable in most cases of primary or isolated cervical dystonia, and in 90% of cases, this will be a lifelong condition. So the posture in cervical dystonia can feature one or a combination of postures as shown in the picture here on screen, and the tremors may also occur, and they tend to be jerky and irregular, and often worse in the direction that is away from their abnormal positioning. So the central issue in dystonia is an exaggerated activation of muscle groups required for the execution of a certain movement. The excessive co-contraction of agonist and antagonist muscles is one of the clinical hallmarks of dystonia. A normal neural mechanism for modulating movement, known as reciprocal inhibition, has been found to be reduced in patients with dystonia. It is traditionally viewed as a disorder of the basal ganglia, but recent studies have suggested the involvement of other brain regions, such as the cerebellum, thalamus, midbrain, as well as cortex. The prevalence of cervical dystonia is 5 to 30 in a population of 100,000. It is commonly affecting those above the age of 30, with the mean age of onset for males to be 39.2 years old and 42.9 for women. Epidemiological studies have shown a female predominance for idiopathic cervical dystonia, with a ratio of men to women of 1 to 1.4 to 2.2. Genetics may also have a role to play, and for secondary cervical dystonia, this can be linked to head, neck, or shoulder injuries. Patients with idiopathic cervical dystonia typically report a gradual onset of symptoms, and this differs from post-traumatic dystonia, where there is a history of recent trauma in the same bodily region. The cardinal symptom of cervical dystonia is painful tonic contractions of intermittent spasms of the sternocleidomastoid, trapezius, and other neck muscles, usually unilaterally, which results in the abnormal head position that you see. Patients may discover that sensory or tactile tricks can lessen dystonic postures or tremors, and this can help clinicians to differentiate between pathophysiologic dystonia from psychogenic dystonia, as these tricks do not lessen those psychogenic tremors. Physical function impairments can also occur, which I'll go through in more details in the later slides. So what are sensory tricks? These are maneuvers that can temporarily relieve dystonic symptoms by the application of a sensory stimulation at an area that's adjacent to the dystonia. The examples would include touching of the chin, the top of the head, or the back of their head. A light touch is often sufficient to elicit a change. Studies have found that these sensory tricks are effective, but the mechanisms currently still remain elusive. It has been proposed that modulation of somatosensory and motor-cortical processing to the mechanisms of sensory-motor integration can help reduce this dystonic activity. So coming back to this picture, perhaps we've been considering our role to focus on the motor symptoms, which is just the tip of the iceberg. However, recent evidence has revealed that people who live with cervical dystonia experience a range of functional and non-motor deficits, which should be addressed in our therapeutic interventions. These findings support the need for a holistic approach to the rehabilitation of dystonia, where our assessments and treatments involve not just motor, but non-motor signs and symptoms as well. All right, so moving on to assessment. Movement analysis is an important aspect and the heart of physiotherapy, and this should be no different in management of cervical dystonia. It involves looking at the position of the neck, shoulders, trunk, and pelvis, both at rest and with movement. An examination should also include palpation and postural evaluation to determine the muscles that have been overactive and contributing to improper alignment. Their responsiveness to sensory cues should also be determined. Active and passive cervical range of movement should be assessed along with the muscle length, strength, and preferred movement patterns of the shoulder girdle, thoracic, as well as lumbar spine. Apart from a focal assessment of the neck as a patient, our assessment should also include an overall functional assessment. Patients with cervical dystonia tend to exhibit impairments in physical function, and hence an assessment including postural control, gait, physical function assessments such as the time up and go, as well as falls and vestibular assessments should also be included. Emerging evidence demonstrate gait deficits and slower walking speed in people with cervical dystonia when spatial temporal parameters were measured. In a study by Barr and colleagues in 2017, 10 people with cervical dystonia were compared to 10 control adults across a range of kinematic measures assessed using an instrumented walkway. The dystonia group on average displayed reduced step length and increased step time, as well as spent more time in double support. The time taken for time up and go was also shown to be increased in those with cervical dystonia, with a longer reaction time as shown in the graph here. These impairments can influence gait and slow walking speed, which can lead to falls. The growing evidence for the involvement of cerebellum in this condition also suggests an impact on balance and function given the involvement of the cerebellum in motor coordination and gait. There is hence some value to add stepping reaction exercises and gait rehabilitation in the therapeutic management of cervical dystonia. So impairments of gait, balance, and vision can also impact people with dystonia in ways resulting in falls. The fear of falling is high in people with cervical dystonia, and this was reported by Barr and co-workers 17 using the fall self-efficacy scale. Falls can be a consequence of the physical impacts of the condition, and common reasons by survey respondents conducted by Boyce and colleagues stated that falls were related to losing balance when they were walking, when they were turning, reaching, or even with stairs. Falling after tripping was also common and could also be a result of dystonic impairments. This can be secondary to impaired vision, balance, or proprioception due to the condition alone, or caused by dystonic impairments causing a difficulty in scanning the environment for hazards. There has also been evidence to show a possibility that fear of falling may be related to psychological rather than physical limitations. The idea, however, is speculative and requires further investigations. So in such cases, improving their confidence from a psychological perspective may be more impactful than physical or exercise-based interventions. Regardless, falls-related fears and falls prevention should be addressed and managed as part of our rehabilitation strategies. So although cervical dystonia is known for its motor symptoms, there is growing evidence that indicates non-motor symptoms are an important part of their condition, and there is a profound effect on health-related quality of life. These symptoms can contribute to disability and a reduced participation in daily activities. What's shown on the slide here are some of the most burdensome symptoms and most prevalent symptoms experienced by patients with cervical dystonia, and I will go into more details regarding pain and fatigue. So pain is a major contributor to disability and social isolation, and it's one of the main reasons that patients seek treatment for cervical dystonia. It is a prevalent and debilitating symptom reported in about 55 to 89% of people with cervical dystonia, when the current knowledge of mechanism is incomplete, with mechanisms being both muscles as well as non-muscle based. This could include an abnormal transmission and processing of the nociceptive stimulus, a dysfunction of descending pain inhibitory pathways, as well as structural and network changes in the basal ganglia and cortex. A common localization of pain is in the neck and upper back, with some radiation going up to the ipsilateral head and down the arm. It is often described as diffuse, sharp shooting, or sometimes a burning pain. About a third of these patients recognize a sensation of pulling in the neck, and 10 to 20% of them will report headaches as well. Another non-motor symptom that's a major issue is fatigue and has been described in 40 to 50% of patients. It is, however, unknown if these symptoms are a response to or related with psychiatric comorbidity, or if they are just a secondary phenomenon in response to the motor symptoms that patients suffer from. Pain, depression, and anxiety symptoms were associated with an impaired sleep quality, and it was shown that fatigue and excessive daytime sleepiness appeared to be a significant contributor to decreased quality of life. This highlights the need for screening of these symptoms in our daily practice and the necessity for treatment of contributing factors such as depression and pain. So fatigue has also emerged as a significant barrier to participation in exercise and physical activity, and is worth further exploration and strategies to manage. So looking at some of the outcome measures that can be used for cervical dystonia. So developed in the early 1990s, the Toronto Western Spasmodic Torticollis Rating Scale is a composite scale measuring the three main aspects of cervical dystonia, being severity, disability, as well as pain. The total score falls within the range of 0 to 85, where a higher score indicates a more severe condition. This has been shown to be a validated and reliable tool. So in recent years, there has been a revision of the initial version, and a simplified scale known as Twister 2 was developed. And they have also included a psych version, which was developed to evaluate the psychiatric features that have been associated with cervical dystonia. Another scale known as the Comprehensive Cervical Dystonia Rating Scale was also developed in 2015, and this measures for motor, pain, disability, and psychiatric complications, as well as the impact of cervical dystonia on the quality of life. This consists of the Twister 2, the Twist Psych, as well as the previously validated Cervical Dystonia Impact Profile 58, and the components of these individual scales can be used separately or together for a complete understanding of the patient. So now we move on to management. Current treatment for cervical dystonia is provided predominantly by physicians, and treatment varies from pharmacological to surgical. The most commonly used and first line of treatment is the use of botulinum toxin into the overactive dystonic musculature. Botulinum toxin A is currently thought to be the most effective medical treatment for cervical dystonia, and the average duration of benefit from the injection is 12 to 16 weeks, with patients needing to repeat this treatment every 3 to 4 months. Other medical management would include oral medications, such as benzodiazepines, baclofen, or anticholinergic agents. Surgical options are considered when a person has not responded to pharmacological or other interventions. And the most commonly used approaches are selective peripheral denervation, as well as deep brain stimulation. So where do we stand in the management of patients with cervical dystonia then? There is evidence that physiotherapy in conjunction with botulinum toxin enhances clinical outcomes. However, there is large variability in intervention modalities across studies that are available. A holistic approach is required, and there is a need to consider a short versus a long-term approach to our treatment, given that cervical dystonia can be a lifelong condition. So these are some of the interventions that have been undertaken as management for this group of patients. They range from active exercises such as motor relearning and posture training to more passive options such as mobilization and taping. Relaxation therapy has also been considered, which includes massage. But what this basically shows is that the variety of interventions that are available for consideration, but whether there's one that trumps another is still a question that has yet to be answered. So looking at this updated systematic review by Kaisei and colleagues, it shows that physiotherapy has a beneficial effect on different outcomes, such as pain, disability, and disease severity. However, the effect on quality of life is still conflicting. A broad variety of physio interventions were used in the included studies, while some focus on exclusive relaxation therapy and motor relearning exercises. 10 studies used a combination of modalities, which included deep massage, active stretches, as well as mobilization of the neck and shoulder. Physiotherapy as an adjunct to Botox was recommended as pain reduction was reported in all included studies. Central changes following physio may account for the improvement in motor function and a reduction in pain. However, working mechanisms requires further exploration. So with regards to the effect of physiotherapy on disease severity and disability, the heterogeneity between the studies was too high to provide any firm recommendations. However, clinicians and patients might still expect improvements following interventions. So based on findings in this review, the authors were unable to state the difference in effect size of physio alone when compared to Botox. However, with a combination of those two, there was reduction in pain, disease severity, and disability compared to just using Botox alone. Further research is required to compare the effects of Botox with physiotherapy alone. And also, up to now, it is unclear how long these interventions of physiotherapy should be for before reaching any optimal treatment outcomes. Another recent review by Bretnam and colleagues discusses the importance of a holistic approach to managing cervical dystonia, given that it is now known that it's more than just a motor condition. So like the iceberg, it seems like motor symptoms are the main problem that needs to be addressed. However, there are many more unseen problems and issues that can contribute to a patient's level of disability and their quality of life. As therapists, we should consider and integrate all these aspects into a patient's rehab, and this can be the key to improving treatment outcomes and their quality of life. A provision of a holistic approach should thus include adequate assessment of not just their physical condition, but non-motor symptoms using validated skills. So given that cervical dystonia may be a lifelong condition for these patients, our role as therapists should be aimed at alleviating some of their symptoms and helping them maintain an overall healthy lifestyle. Further research is required to look into how we can support these patients and guide them with exercise routines and the development of exercise guidelines. All right, so apart from considering what we can offer to patients, I think it's also important to also understand what patients want or find works for them so as to guide our future research and clinical implications. So this recent study by Boyce and colleagues, which was conducted between June and August of 2022, aimed to investigate the use of botulinum treatment and the conservative treatments by patients living with cervical dystonia. 128 responses were collected, with 96.8% living in Australia or New Zealand. The authors found that despite most participants describing their dystonia as mild or moderate, majority of them reported that cervical dystonia had a significant negative impact on their ability to engage in normal everyday activities. Most participants found benefits from regular Botox therapy, and they have also tried various interventions and found effectiveness with heat packs, massage, physiotherapy, and general exercise and relaxation. The pie chart here indicates activities that help participants to cope with their condition. These included getting enough sleep, maintaining interests or hobbies, having the support of friends and families, and keeping physically active, indicating that it isn't just the symptoms that we need to consider, but their involvement with society and how we might be able to help them get back to. This study provides the insights into conservative and self-management treatments that had been undertaken by the cohort of patients, and the information can help us for future research with the aim of developing perhaps an evidence-based guideline for management and self-management. The creation of such guidelines for management can be useful for physios who are not frequently managing patients with cervical dystonia, and to provide the most effective treatment and advice for self-management to improve their patient outcomes. Okay, so looking at what's available in terms of studies, there seems to be a lack of high quality research that's related to physiotherapy interventions, and this highlights the need and opportunity for future studies. Given that each type of focal dystonia is rare and rehab interventions often require multiple sessions or extensive time commitment, this has resulted in small sample sizes in the studies. It is also a challenge to recruit a statistically appropriate number of people to participate in lengthy studies. There is also difficulty identifying the most effective or combination of interventions due to the variety of intervention modalities that have been proposed with different duration and frequency as well. Long-term effects of less intense and longer physiotherapy programs have yet to be explored, and the focus on physiotherapy programs with longer treatment periods and an emphasis on self-management and the ability to improve their performance of daily tasks could be a focus for future research. And lastly, There has yet to be studies comparing the effect of botulinum toxin to physiotherapy alone, given that Botox has always been the first line of treatment for this population. All right, so in conclusion, cervical dystonia is a lifelong and chronic condition. This presentation probably only scrapes the top surface of this topic, but hopefully it has left some impression on how to better approach and manage this group of patients. There is a need to consider a holistic approach to assessment and management of this group of patients, and to consider both the motor and non-motor symptoms that they may present with. What is truly important to the patient? That's the question we should ask. There is a role for us to play in management, and evidence shows that in conjunction with Botox, there has been good outcomes. Perhaps there isn't one ideal form of intervention, and our aim should be towards helping improve their quality of life and towards self-management given the longevity of this condition. Further research is required to identify potentials for an optimal dosage and duration of interventions, the development of any evidence-based guidelines to aid us as physios, and the understanding on the effect of physiotherapy as a standalone treatment. There is more to unpack about this condition that hopefully will be addressed in future. So thank you for your time, and I hope you guys have a good night ahead. Thanks.
Let me unmute. Thank you very much. You could probably stop sharing if you want, Eiling. Thank you very much. Thanks for doing that.
I haven't exited this time.
We have got some questions. If you go to Q&A, you'll be able to see them. Elizabeth Butler asks, is this something seen in Parkinson's disease and maybe not necessarily picked up? I kind of have an aligned question, but answer that first and then I'll shoot mine at you, which is kind of roughly aligned.
I think there has been research to consider cervical dystonia as part of a movement disorder. So that can be in line with Parkinson's disease. And it is, well, I must say that I haven't had much look into Parkinson's and the effects or similarities with cervical dystonia, but I do understand that if they're classified under the same movement disorder, then perhaps there could be an overlap in terms of like symptoms or at least the pathophysiology. Yeah, but
just somewhat along those lines, there seems to be a cluster of symptoms and features. Differential diagnoses, are there things that this commonly gets mistaken for and that physio should be looking out for or the like?
Yes. So are you talking more like mimics of cervical dystonia? Like, yeah.
What's the risk that you think you're treating something else when in fact you've got this condition?
Yeah. So I think, well, in terms of a study that I saw, they did look at different case studies that looked at mimics of cervical dystonia, and it's found that there could be musculoskeletal causes, vascular causes, even GI, as well as ontological causes that could mimic cervical dystonia. And even, for example, like cervical tics, which are motor tics involving the neck, that can also have a dystonia-like appearance. But I think it's important to understand what cervical dystonia is in terms of a diagnosis criteria. And if you find that patients may not be improving with the treatment that you are that they're receiving, whether it's a medical treatment like Botox or from a physiotherapy perspective, then a referral back to the doctor might be good to see if certain symptoms could be due to other underlying conditions.
Okay, good, fair enough. And we've got Eric asking, is routine imaging required for the diagnosis of cervical dystonia?
Yeah. So for that question, based on what I've seen so far, there hasn't been a consensus recommendation regarding the use of routine imaging, because they can, well, based on what I've seen, generally it's from a physical examination and understanding of, the history of the symptoms. But blood tests or MRI can help to rule out any underlying conditions which could be causing the signs and symptoms, but it's generally more of a rule out than a rule in for cervical dystonia. Yeah.
Has any research been done on the effect of laser in the treatment of this condition?
To be honest, I haven't seen studies looking at laser, but is there any, how should I say? I just wanted to find out what kind of effects are you looking at, like more from a pain, or you're looking at laser for the brain specific?
So for this condition specifically, let's say for pain generally, that's a different question. So for this it is for the treatment of this condition. So I'd
Okay.
imagine it may be pain, but it might be other as well.
Yep. I would have to say that it wasn't something that I saw as part of my research. Yep.
Fair enough.
But
Fair enough.
I could look into it and get back to
Hang on.
you.
She said brain specific. Is that the same? I just ticked it as answered. Now I'm going to stuff that up. Brain specific. I think Elizabeth's come back and said brain specific. Is that the
Like deep
it's
brain
just-
stimulation?
Elizabeth, if that's related, can you put it in the chat or another question, please? Sorry, I stuffed that
Yeah.
up.
But I
let's go-
did have a, yeah, sorry. Go
Sorry.
ahead. No, go ahead. Yeah.
With allied health, is dizziness a common secondary symptom adding to falls risk?
It could be. I think given that, with the postural alignment of the neck, I think what has been seen, like headaches and pain could be something that is common for this population. But dizziness specific in terms of a symptom, if I could relate it to the neck, I would think so, but it wasn't something that I picked up when I was looking at their falls. But if I'm thinking more from how the neck relation and where the head is, perhaps that could be something that might be a symptom adding to their risk. Yeah.
Rather than dizziness per se.
Yeah.
Yeah. Okay. So
Yes, baclofen has been there's benefits for them.
how are we going for time? Maybe one or two more. Michael's, I think we have a role in recommending target of Botox, as often the neurologist pain physician default may not be the best. Had a patient who linked the onset of DT to COVID and reinforced by COVID vaccination or vice versa. Is there any evidence for this? Perhaps a vascular clotting factor. What other causes of this condition? Answering this, but if you go more broadly, that'd be interesting.
Sorry, so just making sure I get the question. So it's a link of DT to COVID. Cervical dystonia to COVID. I haven't looked into how COVID presents or the link between COVID and cervical dystonia, but it's definitely something I think, given the recent changes, or rather recent COVID itself, it might be something that would be good to look into for future. But I do understand that with COVID vaccination and an impact of COVID, there could be certain lasting effects of on the human body. But I think it's something that may require further research into. But it's a good question, and I probably should look into it since I've been spending some time on this. Sorry.
Elaine, we'll let
Yeah.
you off the hook. There's a couple more that it'd be nice if you could answer.
Sure.
And answer. Elizabeth's come back and clarified
The brain specific. Yeah.
the laser treatment, those area brain. That's a fascinating question. So I'm not too sure you'd be able to answer it, but if you've got any further on that, just tell us.
Yes.
Okay, I'll let you go, Elaine. Thank you very much.
Thank you.
We must keep moving on. Thank you, everyone, for those questions. And Elaine will type up some answers, and Prue's put the kids to bed, and hopefully, and joined us. Thank you very much for coming in. So what we might do is, if you could do the old share screen business and make sure we're connecting up that way. All right. Welcome, everyone, for our final presentation in this room. It's a chance for us at UQ Physiotherapy to showcase some of the work of our PhD students, who, is a continuum is a degree along the continuum of independence from bachelor, masters to PhD, and particularly focusing on research. Prue is a very active member of our physiotherapy research seminars that occurs on a monthly basis, and has done a few presentations, and as always, come up with some interesting information for us. So Prue, let me introduce Prue. Prue graduated about 13 years ago, Bachelor of Physio, University of Notre Dame Fremantle. That almost makes her a UQ graduate, because they had our program over there at that stage. She has spent the last 13 years working as a physio across a range of clinical areas in the public hospital setting. She's always had an interest in pain. When asked why she is doing a PhD, Prue told me that she enjoys having a chance to think long and hard about things, and to help and others understand how we might better help people with persistent and complex pain. Topic of a PhD evolved from a curiosity around why and how people come to think the way they do about their injury pain. Some people catastrophize, but why? And be very interested to understand your insights here. Personal note, she's a mum of 2 PhD kids. Now, you have to take your hat off to anyone that's had at least one child through a PhD. 2 is going the hard yards. Well done. And I guess when she has some spare time, she tells me she's got some pets and try to get out and do some sport and recreation. I can't imagine there's much time for that these days. And she tells me that it's a balancing act between clinician. I think you told me before, 2 days a week in clinic now up the coast, continuing to complete your PhD and being a full-time mum. So with all that, thank you very much for spending some time with us tonight. Looking forward to your presentation. Take it away, Prue.
Thank you very much, Bill, and thank you so much for having me along this evening to share some of the things I've been working on as part of my PhD. So as Bill mentioned, my background is physio and always really in the tertiary public hospital setting. And I'm currently working at the Sunshine Coast Persistent Pain Clinic, which is a public service. However, the study I'm going to talk about this evening was really based at the Royal Brisbane and Women's Hospital, or RBWH, where I was previously working. And I conducted this study as part of my PhD under the expert guidance of my supervisory teams, Professor Michelle Sterling of Recover Injury Research Centre, Associate Professor Sean O'Leary, Dr. Melita Jamara, and Dr. Nigel Armfield. So imagine back to when people thought the world was flat. If you were on a boat and thought the world was nearing the edge of the earth, you would probably freak out. So in this scenario, society says the world is flat, maps said the world was flat, and visually the world looked flat. Doing some mindfulness isn't really going to stop you from freaking out because you think the world is flat. Now imagine you have ongoing pain after an injury. In this scenario, society generally says that ongoing pain means something is broken, as does the internet, as does your body. So doing some deep breathing exercises might not stop you worrying that you are not going to recover. So I just want you to hold those scenarios in your head just for now. The RBWH sees approximately 6,000 people with isolated extremity injuries, such as wrist, finger, or ankle fractures each year. Most of these will recover without complication. Some, however, will face quite tumultuous paths to recovery. So of those 6,000 people with isolated extremity injuries that come through the RBWH, research suggests that around 10 to 15% will end up with severe and persisting pain. We also know that compared to people with persistent pain without significant disability, people with persistent pain with high levels of disability are more likely to have comorbid mental health conditions such as depression, anxiety, and/or PTSD. This is a problem for both society, with persisting pain costing the healthcare system $12 billion per year, as it is for individuals, costing them $66 billion equivalent in loss of well-being. So how is it that someone with a seemingly simple isolated extremity injury can develop persistent and disabling pain? In my PhD, I'm interested in the role that recovery expectations and more broadly, an individual's understanding of injury and healing plays in recovery after injury. Linking back to those opening examples, what leads someone to have a low recovery expectation or be worried about the injury, and how does this influence recovery? The core question underlying the study that I'm going to talk about is, are injury perceptions associated with pain and mental health recovery after an isolated extremity injury? The intent isn't necessarily to see if there's a causal relationship between these things, but to further explore whether there is a relationship worth better understanding. To address this question, we conducted a prospective longitudinal cohort study recruiting adults aged 18 to 70 from within 3 weeks of their injury. We excluded patients with any kind of major limb trauma, such as significant neurovascular damage, as well as patients with very minor trauma, such as soft tissue injuries. Patients were recruited from the RBWH orthopedic outpatient fracture clinics. We measured injury perceptions using a measure called the Brief Illness Perceptions Questionnaire, or BIPQ. This is an 8-item questionnaire that measures a range of injury-related beliefs and expectations and gives a total score which is thought to represent the extent to which an individual views their injury as threatening versus benign, with higher scores indicating worse or more negative views of the injury. We also measured pain using the Pain Enjoyment of Life and General Activity Scale, or the PEG, anxiety and depression using subscales of the DAS-21, and PTSD using the PCL-5, or Post-Traumatic Stress Disorder checklist for DSM-5. We also measured a bunch of socio-demographic variables, as well as clinical variables such as mechanism of injury and whether surgery was required. We then asked people to complete these sets of measures at within 3 weeks of their injury, at 6 weeks, 3 months, and 6 months after the injury. To see whether injury perceptions were related to pain and mental health after an isolated extremity injury, we used a technique called group-based trajectory modelling. This differs to the typical method for analysing longitudinal data, which called regression analysis. So in regression analysis, this involves looking at the relationship between 2 variables across a whole group or sample. Group-based trajectory modelling identifies groups of people that follow a similar trajectory. This technique has been conducted in other injured cohorts, such as those with whiplash. So just to help you understand the anatomy of a trajectory model, you can see an example here. So on the y-axis is the outcome. In this case, this is the neck disability injury in people after a whiplash injury. On the x-axis, we have time. So the lines or the trajectories are groups of people who are predicted to follow a similar pattern of the outcome over time. The dashed lines around those lines are the 95% confidence intervals, and the percentages on each of the lines is the proportion of the sample that are predicted to follow that trajectory. So it's important to note that these don't necessarily represent clear-cut, mutually exclusive groups. Individuals in a sample are assigned a probability or likelihood of belonging to each group. So someone might have a 60% chance of following one, but a 40% another. Also note that the number of groups are decided through a combination of statistics and clinical knowledge after modelling the data. We don't force the models based on cutoffs, but let the data speak for themselves. So what we can see in this trajectory model is that 45% of the sample are predicted to follow a mild disability path versus, for example, 16% who are predicted to follow a chronic severe trajectory. So with this prior research in mind, we set out to see if we could identify distinct trajectories of injury perceptions, pain, and mental health in people with isolated extremity injuries. We also wanted to characterize those trajectories if we could identify distinct ones, and to see if there was any overlap between injury perception trajectories and pain and mental health trajectories. So by this last one, I mean, given a person is likely to follow one trajectory group, what is the probability that they will also follow another? So before we jump into the results, some brief characteristics of the sample we recruited. Of the 669 that were invited, 163 consented and 84% completed at least 2 of the 4 rounds of surveys. Of those 163 people that consented, on average, they were young, not surprisingly, given the nature of the injury, and 2/3 were female. They were, on average, quite well educated. Compared to those who did not take part, there was no significant difference in socioeconomic status or age, but there was a difference in sex. So 54% of those who did not take part were female versus 63% in our sample. They were also on average quite healthy. 11% were receiving treatment for persistent pain unrelated to the injury prior to having the injury, and 1 in 5 had pre-existing mental health conditions. Most of the injuries were managed conservatively. There was a 40-60% split in upper limb and lower limb injuries respectively, and half of the injuries were caused by a slip, trip or fall. So this is where this sample differs to, for example, a whiplash cohort, where the mechanism of injury, generally speaking, was fairly innocuous. So it wasn't things like car accidents or major trauma. So now we arrive at the juicy bit. So remember that our first aim was to see if we could identify distinct trajectories of injury perceptions, pain and mental health, and to characterize these trajectories. And by characterize, I mean we're looking at how many trajectories are there and what do they look like? Are they going up? Are they going down? Are they flat? So to orientate you again briefly, x-axis is the time in weeks and y-axis is perception of injury in this graph. So measured using the brief illness perception questionnaire, where scores are out of 80 with higher scores indicating higher perceived threat. So for injury perceptions, as you can see, we found 3 trajectories. 35% of the sample were predicted to follow the low perceived threat group, so they weren't very worried about their injury, compared to 21% predicted to follow the high perceived threat group. Cutoff scores for the BIPQ have not been calculated for people with minor limb injuries, such as people in this cohort. However, in people with spinal cord injury, it has been looked at, and they found that scores of less than 42 place people in the low perceived threat group, whereas scores more than or equal to 50 were categorized as high perceived threat, which you can see fairly well overlap with the scores that you can see in this graph. As for pain, also we found 3 trajectory groups. So once more, time on the x-axis. On the y-axis, we have pain-related disability measured by the pain enjoyment and general activities scale. So 0 is low pain-related disability, 10 is high. So again, you can see a good group, an improving group, and a not so good group there, which you can see seems to be worsening over time. Compared to the injury perception trajectories, we can see that the confidence interval for the orange and red groups were overlapping until the 12-week mark post-injury. So if these confidence intervals had continued to overlap over time, we would say that these are not distinguishable trajectories, but you can see that there's that divergence there at that 12-week mark where they seem to separate. As for anxiety, this one was a little bit different. So we found that the best fit to the data was actually 2 trajectories, a high group and a low group. So for context, we were using a subscale of the DAS-21 to measure anxiety, and according to the DAS, scores of 15 to 19 put someone in the severe depression category, so you can see that red group were fitting that severe category. As for depression, we found 3 trajectories again, and scores of 21 to 27 for the depression subscale, the DAS placed someone in the severe category. So you can see that third group is starting to head into the extremely severe category. Do note that it's only 6% of the sample, so not huge. And finally, for PTSD, again, 3 trajectories, again, noting that that third, so the worst group was only 2% of the sample. So we could actually make it 2 trajectories, and therefore that third group was being absorbed into the orange group. We decided to keep it at 3 just to not lose that third group, because even though they're a small group, they're potentially a clinically relevant group, and what you'd want to do is see if you could if this finding was replicated in a larger sample. And again, for context, scores of 33 or greater on the PCL5 indicate probable PTSD. So now we get to our third aim: how do injury perceptions relate to the other trajectories? To orientate you first, each bar here represents an injury perception group. So far right is the worst high perceived threat group. The middle is the moderate group, and the far left is the low perceived group. the low perceived threat group. So within each of these columns, we can see the probability that they will follow a certain trajectory of a different outcome, in this case, pain-related disability, given that they belong to that trajectory group. So here you can see that if a person has a very negative perception of the injury, they're very worried about it, they don't think they have any control over it, they think it's going to take them a long time to recover, there's a 90% chance or near 90% chance that they will also follow a high pain-related disability trajectory. Conversely, if they are in the low perceived threat, predicted to follow the low perceived threat injury trajectory, there is a 0% chance that they will have high pain-related disability. So same graph here. Again, each column represents an injury perception group. So the far right is the people who are very worried about their injury, except now we're asking the question, what is the probability that they might have high versus low anxiety, given that they follow a certain injury perception trajectory? What we can see here is that no matter whether someone had high, improving, or low perceived threat about their injury, there was a relatively low probability that they would also follow a high anxiety trajectory. So, for example, there was a 56% probability that someone would follow a low anxiety trajectory despite being in a high perceived threat group. So being worried about the injury didn't necessarily mean that you were also anxious. Regarding injury perceptions and depression, there was a diminishing probability of having low depression as perceived threat increase, but still a 12% chance that a person was predicted to follow low depression trajectory despite being in the high perceived threat group. And finally, for PTSD, if you had a high perceived threat of the injury, there was a 40% chance that you would be, in the high PTSD trajectory, and a 60% chance you'd be in the moderate PTSD trajectory. So it would seem that of anxiety, depression, and PTSD, injury perceptions trajectories seem to overlap best with the PTSD trajectories. So if you're feeling a bit like this now, I don't blame you. It's late on a Friday. What I'll show you now might help you feel a little bit like being back in the land of clinical reality. So in large samples, group-based trajectory modeling allows us to determine predictors of belonging to different trajectories. So, do a certain younger versus older, does certain sex predict whether you belong to a trajectory? Our sample size didn't quite permit us to do this in a robust way. However, we could look at descriptive statistics to identify some trends. So what these figures show here is the percentage of people with certain characteristics in the high perceived threat group versus the low perceived threat group. So for example, 73% of people in the high perceived threat group were female compared to 66% in the low. 21% of people in the high group came from a lower socioeconomic area versus 4% in the low. There was a higher probability of people having a lower limb injury versus people in the low group, and a high proportion of people in the high threat group required surgery, had pre-existing pain, and rated their general health as poor. There were, however, no differences in age, education, BMI, comorbidities, or prior mental health diagnoses. So whilst we can't strictly call these predictors, as we need to do this using regression modeling, factors such as pre-existing pain and post-traumatic stress symptoms do seem to consistently appear as risk factors for poor outcomes in these sorts of cohorts. So these data show that there are people who are very worried about their injury right from the start. It appears that people who have high perceived threat of the injury also have high pain-related disability and, to a lesser degree, depression and PTSD symptoms. But you could equally flip this and say that those with worse pain and mental health symptoms had worse perceptions of the injury. So maybe it works that way, or perhaps it works bidirectionally. So we can't conclude from these data that we ought to be fixing someone's injury perception to improve pain and mental health recovery. Perhaps we may need to improve pain and mental health to then improve injury perceptions. However, we can, there is a case obviously to further explore the relationship between injury perceptions and pain and mental health recovery after an isolated extremity injury. And a very sincere thank you to my supervisory team thus far. I've still got a way to go. It's by no means finished. And also hugely indebted to the Royal Brisbane Women's Hospital Physio Department and Royal Brisbane Women's Hospital Foundation, who supported me in particular to do this study. Thank you very much, everyone. Any questions?
You can unshare if you want. Remember, guys, Q&A box for any questions that you'd like to raise. There is one there, but I was interested, and just because I don't know of my perception, but you had 47% of the people had a bachelor's degree. Is that going to the Royal Brisbane Hospital? Is that kind of beyond expectation, or is my perception?
So there's a few things there. One is that typically, I mean, I'm sure you know this anyway, but you know, with these studies, because you just naturally tend to, the sort of people that say yes to doing it, you kind of skews that, because you end up, you know, you hand out an 8-page patient information and consent form, and that kind of rules out a lot of people, unfortunately, with, you know, lower education levels. So that's one. I did actually wonder, I thought, well, how does 46% compared to the general population? And I looked it up, and I think the census, the latest census data suggests that I think around 30% of the whole population, you know, who are, you know, adult population, have a bachelor degree. So it is lower. Yep. But when you look at the breakdown in numbers, it's always much higher in females, and we had more females in our study, and also younger populations obviously more likely to hold it. So it's not that surprising that 46% held a bachelor, okay, but certainly higher than you would expect, you know.
Because it was going kind of, I guess I'll continue on. I was going to ask, and it's probably more from your research and how you present it in your full thesis. You've got a very small percentage of people that actually you captured data from, 84% of the small lot that agreed to do it. You've got a lot of people you missed. Mm. How applicable is the information you got, or have you got a way of, or not, of trying to understand what the difference.
Yeah. So because obviously there's only so much data that you can collect on the people that didn't consent to taking part from an ethics point of view. I could, though, to do at least a, you know, rudimentary screen of the differences between those who took part and those who didn't. I was able to get determine the socioeconomic status, age, and sex of those who didn't take part. And so there was no significant difference in socioeconomic status, which is probably a good one that there's not a massive difference in. Yes. No difference in age, but there were a high proportion of people who took part in this study that were female. So 63% were female versus 56%, I think, of in those people who didn't take part. But I couldn't ask them. There was no way of checking the level of education of those who didn't take part. But socioeconomic status, to a good degree, would be a little bit, you know, aligned with that. So yes, there's differences. Hopefully, you know, not so much that it isn't, you know, still fairly generalizable.
If I can pick up on something like that, I'm sure some reviewer, when you submit a paper, is going to do it, and so you have to have something to preempt it.
Yeah, that's it. Yeah. But I think that's why we should be transparent about it, rather than, you know, pretending that they are. And I think it's hard to. I think we could definitely do better at making that whole consenting process a bit more attractive to people who, you know, we want to capture people that maybe have lower literacy levels and things like that. But it's quite there's a lot of barriers to them taking part in these sorts of things.
It's not easy, not easy at all. Now we have got a couple of questions. If you open up the Q&A box, first one is you said mostly sport injuries, but they were wondering what percentage may have been compensable, eligible for legal claims.
Yeah, so I did actually get that data. So I asked whether they lodged a compensation claim. I can't off the top of my head give you an exact percentage. It was low. So I think it was, I actually do remember looking at it. I think it was 10, somewhere between 10 and 15% of the people lodged a claim. So it's small numbers. And I have done very rudimentary look at, whether there was an association between whether they'd lodged a claim and the recovery trajectories, but not enough to sort of tell you for sure yet how much that plays a part, because it was a small proportion, given that, like I said, most of the injuries were sort of slips and, tripping over pavement and things like that.
Yep. Good. And the other question is from Michael. Appreciates your presentation, very great one, and I will concur with that. Is there an opportunity for looking at injuries in the compensation system of similar injuries rather than WOD?
Definitely. So I'm assuming you talking about only looking at people who are going through the compensation system. I'm sure that, obviously there is that established link in the WOD cohort on the effect of compensation on their recovery. So it would be interesting to see, if we saw similar things in a larger group of people, who had lodged a compensation claim with these sorts of injuries.
Yep. Cool. Okay. Here's another one. Would health literacy be impacted by these data with the participants, thinking high ATSI population here in WEPA with low health literacy?
Yeah, I'm sure. We didn't I know there's specific measures that you can use to establish health literacy, and I've no doubt that it plays a role, but we didn't sort of formally measure health literacy. Again, going back, I guess, to sort of even taking part in the study requires some level of, health literacy, understanding the importance of research and things like that. In health can tends to attract a certain sort of person, and unfortunately there's a distrust, I think, sometimes in research institutions, which can put people off taking part. So yeah, no doubt it's a factor, but we didn't formally measure it.
And we're almost out of time, but Yoga Physios asked a question. Curious to know a bit about the diagnosis of PTSD and the possible relationship with perception of threat. I think it's really underestimated the trauma impact of injury, perhaps related to a lack of understanding about body healing. Is that more comment or question? Do you have anything to say about that?
Yeah, and it's kind of, I think your comment is a little bit, it really is sort of kind of gets to almost what motivated me to tap into or dig into the, injury perceptions more. And I did, because I was sort of thinking, what is behind people's sort of, when people are worried about recovery, what is it? Is it, I mean, obviously the default or the sort of most common thing we think of is that it's just things that they get told by the healthcare professionals, but I feel like it's more than that. I think it goes back to, how people, how they were told about their bodies and health growing up and things like that. So I did actually embed a qualitative component in this longitudinal study. So I took a subsample of people who were either recovering well or not recovering well, and then asked them what they thought about their injury, and to try and get a little bit more understanding from, using a qualitative approach into as to, what sort of things influenced their understanding of their injury. Not necessarily looking, specifically at post-traumatic stress. I can't really comment on that, but definitely on that sort of, what is it that influences people's understanding of their health, of their injury, of their bodies.
Cool. Thank you very much for that. And well done on that, the way you represent the data. That's not easy to do. And Sean emailed me just to let me know that he had full control of all that data and was leading light in showing how to do those analyses.
It's definitely a bit of a brain twister for a Friday night. Some of those bar charts, I'm sure, still having a few people scratch their heads.
Oh, well, yeah. Well, but I think you did very well in the way the arrows and that and trying to do it. I think it could have been a lot more difficult to see. So I thought you did that very well. Thanks for that. And you're right. Yeah, last thing on a Friday. I might there's a lot of thank yous, I think, rather than questions.
So Michael is a physiotherapist at the Canberra Hospital, and the Canberra Hospital provides care to the ACT and surrounding New South Wales regions, providing a mixed caseload of sports, farming accidents, and occupational and high-speed motor vehicle injuries. So here is where he found his passion in rehabilitating acute traumatic musculoskeletal injuries with a particular focus on upper limb injuries. And therefore, his topic for today's session. So take it away, Michael.
Yeah, thanks, Ziki. So let me just start my timer. So today I'm going to be talking about functional humeral bracing for humeral fractures. So what it is, how we do it, and why we do it. So please ask questions along the way, and I'll do my best to try and answer these at the end. I just would like to take some time to acknowledge and thank ACT Health, Canberra Health Services, and the Acute Physiotherapy Department for providing financial support and study leave to actually complete this coursework. It's very much appreciated. So in clinic, you may see a patient who has sustained a fractured humerus, like the ones that you see on the screen. Is your first thought that they need surgery and physiotherapy has nothing to offer initially? Over the next 20 minutes, I'm going to discuss how all these images can and have been managed conservatively with good patient outcomes with a fraction of the cost associated with surgical intervention using a low-cost bracing option. But first, let's just start off with exploring some data on humeral shaft fractures. So humeral diaphyseal fractures account for 1 to 5% of all long bone fractures and result in severe disability, pain and functional impairments for months after injury. Nearly 50% of these fractures occur in the middle third of the shaft, and 55% of them occur in the female sex. The sex distribution has an age component associated with it, and it can be seen on the graph on the bottom right-hand corner there. Males are more likely to fracture in the third decade due to risk-taking behaviour and road and sports trauma. Whilst females have a higher incidence in the later years of life, peaking in the 8th decade, which is associated with higher risk of trauma, higher risk of a low trauma event, including falls. So data obtained from an epidemiology study of 900 people reported the different mechanisms of injury for these fractures. Humeral shaft fractures are associated as a fragility fracture, as 73% of these occur from a standing height and usually in that older population. Then we go down to 8.3, which are associated with sports injury and usually occur in that younger population. And then further down, the smaller percentages from road-related trauma, falling from a height, which is usually occupation-based, and then other, which can encompass those pathological fractures. So really there's 3 different management approaches that exist for these humeral shaft fractures. So immobilisation, surgery and functional bracing. So immobilisation was and it remains a mainstay in fracture management, and we use those guiding principles that involve restoring the bony alignment and then controlling those deforming forces of the muscles and joints and gravity through rigid fixation. This method is associated with joint adhesions and atrophy. Then we move on to surgical restoration through compression and dynamisation, and it was thought to be creating this optimal environment for fractures to heal in. It allowed early mobilisation to limit joint problems and muscle atrophy, but was associated with higher costs and morbidity and mortality. And given the higher age group of the population sustaining these fractures, who often have significant comorbidities, they may not be actually good surgical candidates. And another risk factor for this group is that you can get this radial nerve palsy, and we'll discuss that a little bit later. At around the same time, functional bracing was explored, and it was a radical move away from the traditional surgical and conservative management approaches. It freed up the adjacent joints, it allowed gentle movement to limit atrophy and joint adhesions, and demonstrated that movement at the fracture site actually enhanced osteogenesis rather than being detrimental to the fracture healing. And this started in tibial fractures, and it's since been moved across to other sites, including, forearm and humerus. So how does a functional brace for the humerus actually work? So a functional humeral brace is a hard circumferential plastic sleeve with elastic or Velcro to tighten or loosen the device to accommodate for swelling and atrophy changes. These can be off-the-shelf braces or custom-made thermoplastic braces that allow free movement of the elbow joint and the shoulder. The main function is to compress the soft tissue surrounding the fracture. The hydraulic effect of the brace compressing the soft tissues with the addition of gravity and the contraction of muscles provide fracture stability and realignment occurs. Elbow movement is thought to be particularly important with functional humeral fractures, as it assists with derotation by utilising the line of the pull of the biceps and triceps to restore that anatomical alignment. And because of this, manipulation of the fracture prior to brace fitting is not normally required. Over time, with gravity and movement and bony remodeling, bony alignment is restored. Literature reports it's considered the gold standard approach for diaphyseal fractures of the humerus due to its low cost and good functional outcomes. So we'll take a look at those outcomes now. A systematic review and meta-analysis was conducted examining the short and long-term outcomes of humeral shaft fractures managed conservatively and surgery by Oliver and colleagues in 2023. 292 patients were included across 6 studies, and they were included in the analysis. So when examining the short-term outcomes of 3 months, surgical fixation was superior for functional outcomes using the DASH as their outcome measure. However, pooled analysis of pain scales demonstrated no difference. Past 3 months, no differences occurred between the surgical group and conservative groups for pain and function. Additionally, the Hummer study was a prospective cohort study which examined short and long-term outcomes of operative and non-operative management. They included 390 participants, and their outcomes are pictured on the right in the graphs there. So outcome measures that they used was the DASH, the constant Merley, and that includes a patient-reported outcome measure section of pain and activities of daily living, plus objective measures of movement and strength. They also utilised pain and returning to their usual activities through a numerical rating scale. So on those graphs, the blue line represents operative management and the red is conservative. On each graph, you can see a difference for the DASH and the constant Merley at 3 months. However, past 3 months, there's no difference between groups. So if surgery provides those superior short-term functional benefits, why is conservative management considered the gold standard for this fracture type? And it's because of these adverse outcomes. So surgery is associated with a high risk of infection and radial nerve palsy. And the risks for re-intervention or non-union are still present. The non-union rate for conservative management of fracture is 15.7% compared to 8.3% in surgery. The difficulty when interpreting this non-union rate for conservative management lies in the various variations in research methods, protocols, and surgeon-directed care. Variations occur for when functional humeral bracing is initiated. So some is immediately, and then others is 2 to 3 weeks after injury. And then when the movement was initiated, and that ranged from when the brace was put on to waiting 6 weeks, and then also what type of movement was permitted, which is very different from the original methods published by Sarmiento in 1977, which reported that they put the brace on and they could complete active and passive movements of all the fractured extremity joints immediately. And in his population, he had 51 were included in this review article, and only 1 out of those 51 reported non-union. When patients do go on to have non-union from conservative management, evidence suggests that they still have excellent to good functional outcomes. They're still achieved with surgical fixation and dynamisation. Radial palsy is also one of the most significant risk factors for humeral shaft fractures and surgery, with an incident rate of 17.4 in the surgical group compared to less than 1% in conservative management. Radial nerve palsy is characterised by the inability to extend the wrist and fingers, with a loss of sensation in that radial distribution, and has significant impact on the ability to function and use the upper limb. It's usually associated with surgery of those significantly angulated, complex or traction fractures, and significantly lengthens the recovery time up to 9 months to 2 years. If a radial palsy does occur within either group, all is not lost. Most recovery occurs through natural recovery of the nerve and rehabilitation, which includes stretches, active movement, and potentially using a torque transmission orthoses to augment the finger extensor movement through wrist flexion. And you can see that orthoses on the bottom right-hand corner there. And if you're thinking that might be helpful, referral to a hand therapy clinic might be indicated. So fracture type or complexity is related to the presence of radial nerve palsy, but does it actually influence recovery time? So fractures are classified using the AO fracture and dislocation classification scale of simple, wedge and multi-fragmented. Koch and colleagues examined the outcomes of conservative management based on fracture classification. Type A, or those most simple fractures, had a clinical consolidation at 8 weeks. So that is when we push in it, there's no pain. And when we give the fracture a bit of a move, it doesn't move. And then radial consolidation, which always lags behind what you can see clinically because of the density is required to be seen on X-ray. Type B and C fractures have longer times to recover and to heal. So this information is really helpful to inform patients about how long they can expect to be in the brace. So at the start, I mentioned we don't need to manipulate or realign fractures to have good outcomes. And there's some surgical guidelines that suggest this, 20 degrees of anterior posterior angulation, 30 degrees of varus valgus, and 15 degrees of rotation, 3 centimetres of shortening. They would be appropriate candidates for surgery. However, a cohort study by Shields and colleagues in 2016 examined physical outcomes and function and shoulder movement after this, and their results suggested that 30% healed in varus and valgus greater than 30 degrees, and 40% healed in greater than 20 degrees AP angulation. And there was no difference on patient-reported outcomes, the DASH, shoulder active movement, and quality of life. You can see the natural progression of bony remodeling through the use of the brace and movement and gravity. So image A on the left there is the initial radiograph with displacement and angulation. By 4 weeks of using the brace, you can already see it starting to realign. And then at 4 months, you've got some really nice bony callus forming there. The brace is designed to allow gravity and soft tissue to realign the fracture fragments. And that remember that bones are adaptive and it responds to load. So not only is there functional benefits to conservative management, but also cost savings. A cost analysis study was conducted in 2023. It looked at the total costs associated with care for surgical and bracing, and included the ED presentation, medication, medical imaging, surgery, rehabilitation, and productivity lost. With operative treatment being the white and black kind of squiggly line that you can see, and then the conservative group being the alternating white and black. So overall operative fixation is associated with higher costs, mainly due to the association with surgery and the hospital stay, and it equates to about $12,000 US. Non-operative costs were higher in emergency visits, attending consecutive appointments and medical imaging, and then a lengthened recovery time with increased costs with home care help, physical therapy, and productivity lost. This option still has a saving of about $3,000 overall. So what do patients tell us who have lived through this experience of a humeral shaft fracture? Karimi and colleagues completed a qualitative study of 12 patients and found 5 themes. So the first one being expectation. So when patients presented to care, many found there was a mismatch in how badly they thought their arm was compared to the care that they received. So that was, they broke their arm and all they got was a sling or a brace. Additionally, the quality of information did not address their concerns, and many didn't understand why they were actually having surgery. Patients want to understand how to best manage their physical changes, such as, fracture mobility if they feel it moving or if they've got pain, and what to do when they have swelling or fracture movement. How do they actually manage this? They also need supports in place and information to help manage independently, whether that be one-handed living education or home support, such as, getting help to shower. They desire information about the expected time to recovery and what this can mean, if they're having surgery versus if they're conservatively managed. They also want information and management tools on how to deal with the psychological effect from a humeral fracture. And so we know that that's a big factor in this injury, such as fear of falling, or how do they actually get back to participating in their usual activities or modified activities while their humerus heals. These 5 factors were one of the main reasons why patients represented to ED or a fracture clinic without limb-threatening condition, just because they didn't understand it. And as physios, were well placed to communicate with patients, to collaborate with them, to self-manage with real expectations around brace wearing, when they can return to function. And we can provide them with the information of what to do, if they get a swollen arm or if they feel the fracture moving, how to sleep, and to live with one hand. So how do we actually do it? So we have the patient sitting with their arm supported, we remove their brace or their sling, complete some skin care, we apply a stockinette to protect their skin, and this can be changed weekly, and then we fit the brace. So this is best done with the patient leaning over to the side to create space between their axilla. We apply it, and it should be firm, as again, to compress that soft tissue. You need to cue the patient to stay relaxed in this position, and that's to minimize the movement of the fracture as much as possible. If pain is present, muscle spasms of the deltoid occurs, and fracture movements, can occur, and you can see some nice skin tenting there. So simple cues like relaxing the elbow to the ground can be really helpful. Before and after, you need to complete a neurovascular assessment, and if any changes occur, ED or orthopedic review is warranted. So patients are usually seen in ED for this fracture due to the severity of pain and disability, and they've had their, neurovascular check done, and orthopods being consulted, imaging's been done. And that's where, physio, we can come in if they're for conservative management. We can apply a comfortable brace that limits that fracture movement. We can start them on their exercises, provide them tailored education. But when is the optimal time to actually begin that functional bracing? And the exact time to initiate that bracing in the literature is really varied, from immediately in the ED to waiting 1 to 3 weeks for swelling to subside. And when looking at outcomes, there's no difference seen. So if a patient is pain limited, they're swollen, placing them in a plaster of Paris or coaptation, splint, sugar tongue, hanging U slab may be indicated, and the functional brace can be applied later, but potentially in your clinic. However, if their pain, is relatively controlled or they're not too swollen, putting them in a brace straight away would be reasonable. I think the main message here is to be really patient-centered and base it on their symptoms and what they're feeling comfortable at that time. The next thing is when to start movement. So the key to good functional outcomes with a functional brace is movement. We know that movement helps with the fracture realignment, edema management, joint restrictions, muscle atrophy, and pain modulation. And that bone is that adaptive tissue that responds through a complex interaction of cellular biology processes that respond to mechanical stimulus to heal. And as physios, we're really well placed to help a patient navigate that tightrope of completing exercises to help tissues heal, but they're not doing too much to actually tip the balance. So how do we step them through, from having an injury to getting the full benefits of using a brace? So it might be just starting off with some really simple passive movements of the elbow and then moving towards more active ones. followed by shoulder pendulum exercises, and then moving on to active assisted and active, and then just functional rehabilitation. The patient is in control of how much they can do at the start, and we're just going to assist them through the various stages of recovery, just like what we do with other injuries. This may also require a conversation with an orthopod if they ask for a functional brace, but then ask them to be immobilized for 6 weeks, because then it isn't a functional brace. Function and movement is key. Some of the key problems that arise include pain and fracture movement, as I've said. So the patient should only complete what they are capable of doing and should be able to self-adjust the brace to improve that compression. So other considerations you need to think about is how they sleep, how they sit, and how they move. We want to utilize gravity to our advantage. So when sleeping or sitting, not using pillows to support under the arm, utilizing a collar and cuff to help gravity to traction that long arm down. Sleeping can be in an upright position, just to help again with that gravity. And movement is key. So it's as tolerated with the brace firm to compress that soft tissue. And that providing them education that a little bit of fracture movement is pretty common for them to feel. They might feel it, grating or sliding there. So they can adjust the brace if they need to. And then giving them some strategies about edema management. So elevation, doing some soft tissue effleurage, some hand squeeze and so on. So just in summary, I guess physios can have an immediate role in managing these injuries, just using a really low-cost functional brace. The brace should fit firmly to compress the soft tissue, so that's key. We're not actually splinting the break itself, we're using the soft tissues to do that. Education is key, so we need to encourage them for self-management, and it should include aspects of how to care for the brace, how to adjust it, do their exercises. And that movement is a key component to this functional bracing, and it should begin as soon as possible post-application of that functional brace. And that's everything. There is some references at the end if anyone is interested.
Thanks for that, Michael. We do have a couple of questions in the Q&A. So if you could open the panel on it, you can have a look. Can you see the questions then?
Yeah, so the CHS Audis, so they're talking about humeral length, either from bone lengthening or shortening, and its effect on elbow range of motion. And the short answer is no, it doesn't have an effect on that. So there was a study that looked at both shoulder range of motion and elbow range of motion after this. And they found that if there was, 3 centimeters of shortening or lengthening, that actually the muscles and, the muscles were actually able to accommodate for those changes. So it's pretty, flexible and resilient if it does change. Yeah. So the subcapital humerus fractures, I'm not super sure about the location. I know that when you get up towards that humeral head, the main thing is you just put them in a sling, but probably from that surgical neck of humerus down, the literature just supports that you can be managed in a Sarmiento or functional humeral brace for them. I know originally originally I thought it was just for those mid-shaft humeral fractures, but there's some literature now that supports across the whole length of the humerus there. So Jenny is asking about patients removing it for hygiene, and the answer is yes, they can. You do want to limit it. I think in the literature they talk about it, being weekly there to, limit the chance of the fracture fragments moving too much. But yes, they can take it off, and it's the same kind of process of applying the brace. They just lean across and perform some gentle skin care particularly in those early phases. As you get further along and there's, that fracture consolidation, there's less risk of that occurring. And particularly when they've got that full elbow range of motion and a little bit of passive or active shoulder range of motion, it certainly makes completing that personal care a little bit easier. And the elbow range of motion is probably one of the key things that you want to get back, in the first instances. So that would be one of your key things that you would focus on initially, is getting the active and passive movement there. So when they do start doing their pendular exercises, it's a little bit more comfortable for them. Sorry, Noel, I'm not sure. I'm not sure about the risks or prevalence of upper limb DVT post-ORIF or bracing. I didn't go too much into the medical side of it. Yeah, so there is no restrictions on how much shoulder range of motion a person can do. If you look at the various kind of methods in there, when it was first reported by Sarmiento, there was no restrictions. The patient could use their hand functionally how they felt. Initially that's not going to be using their hand for functional activities, but we don't like to put any restrictions on range of motion there. Andrew, so I guess, if you go through the public system for this, if you go through emergency and you've seen your orthopod and you go back to fracture clinic, you're right that, they would use a Sarmiento brace. In private practice, if you see a private orthopod for a review, and they might send you to a physio practice, they might put the brace on there. I guess it's a bit of a moving feast, because they're always coming up with different surgical techniques, and I'm not going to go into the differences associated with that. That we may actually end up with a point where actually surgical management is better for these patients, rather than being managed in a brace. But from the literature, pretty much anyone from really young children, so we're talking in the 10 years or younger, all the way up to kind of 90-year-olds, can be managed in these functional braces and end up with good outcomes. And I'm not super sure, Amol, about the comparison between Sarmiento braces versus collar and cuff. I do know that, the collar and cuff is a management option for those higher, humeral head type fractures. But something that, I could look into or something. Not super sure about that one.
All right, thank you, everyone. Thanks, Michael. That was very interesting, and we had some very engaging questions there. So thank you, everyone, for that. So next up is Zach. Zach, would you like to share your screen, please? And while he's doing that, I'm just going to provide you an introduction for Zach. So Zach has worked in the public system as well as in private practice, and he has found it very interesting to experience both what he finds as contrasting models of healthcare delivery. And he's hoping to combine both skill sets to eventually move into advanced practice primary contact roles. Now, he personally enjoys riding dirt bikes and has supported the physiotherapy profession substantially as a result of his numerous traumatic injuries and rehab journeys. So the reason why he wanted to do this topic was because he wanted to take a deep dive into trying to understand what he feels could be a rather mysterious condition. So he has found exploring these concepts underpinning the condition very fascinating, but also soul destroying. So let's get to it. Off to you, Zach.
All right, thank you very much, Ziggy. Let me just start my timer as well. So the T4 syndrome diagnosis, when I first started looking into this condition, it was really about exploring the physiological mechanisms of how the symptom distribution seen in this condition is possible. But the more I looked into it, the question became more about, does it even exist? And if it does exist, what can we do about it? So I'll see how I go answering a few of those questions over the next 20 minutes. So what is T4 syndrome? It's a condition that kind of first got mentioned in the literature in the 1950s, but probably went more mainstream in the 80s when guys like Jeff Maitland and Nick McGuckin both wrote separate textbook chapters on the condition. And Nick McGuckin actually apparently had a case series of over 90 patients, but it wasn't really properly reported. It kind of went out of fashion a little bit more recently, but it's still spoken about, and it's still featured in contemporary literature and textbooks such as Bruckner and Kahn's Sports Medicine. And it's basically, it's a vague constellation of symptoms that's thought to be caused by thoracic joint pathology, where intervertebral or facet joint degeneration can cause irritation or ischemia or entrapment of the sympathetic nerves, and then decreased sympathetic nervous system activity. And despite the name T4 syndrome, it can actually involve any of the upper or middle thoracic segments, any of the thoracic segments that have sympathetic nerves that then flow on to the arm or the head. So the symptoms that it can reportedly cause, obviously the local upper thoracic pain and dysfunction, obviously related to the actual joint pathology. And then you can have neck and interscapular pain and chest wall pain as well. And it can go up as high as the head and cause headaches. But then probably the hallmark feature is you can have this unilateral or bilateral arm and hand sensory symptoms. And they're often described as these vague, unusual sensations like paresthesia or fullness and tightness or coldness. And they're descriptions that are typically associated with autonomic neural dysfunction. And they're also in a non-dermatomal pattern, so often the glove-like distribution that you see in the diagram on the right, and it can be bilateral as well. So obviously that's not really dermatomal, and you can have pseudomotor and vasomotor symptoms as well, like temperature changes, skin color changes, edema, things like that, and that's due to the sympathetic nervous system obviously being responsible for controlling the sweat glands and the blood vessels. So obviously it's a bit of a weird distribution in this condition. So I want to talk a little bit about the anatomy and a few things that it's not to start off with. So radicular pain with or without radiculopathy is the entrapment neuropathy that we'd be all familiar with, where the somatic nerves get affected as they exit the spinal cord, and they cause symptoms and dysfunction in either their sensory or motor distribution, basically. But if you look at the diagram, you can see that the dermatomes don't really fit. T1's the only thoracic nerve that really has a significant contribution to the upper limb innervation via the brachial plexus, barring some small communications from T2 and sometimes T3. But even then, it doesn't really explain the circumferential glove distribution that you see, or the bilateral distribution, and it certainly doesn't explain the headaches. And it doesn't really make sense when the joint pathology is below T3, which in majority of cases it is, as the name T4 syndrome suggests. Obviously, you've got somatic referred pain as well, that can come from either the interspinous structures or the facet joints, and that's caused by convergence of neighbouring primary somatosensory afferents on common secondary somatosensory afferents. But as you can see, from the pain referral pattern studies that have been done, it doesn't really explain the widespread symptom distribution that you see in T4 syndrome either. So what am I talking about? I'm talking about sympathetic outflow, so the actual sympathetic neurons. So the diagram on the left of the spinal cord, you can see the black lines exiting on the left, and they represent the preganglionic sympathetic fibers, and they actually only exit at the levels between T1 and L2. So unlike the spinal nerves, they don't come out at every level. So obviously some of those fibers have to ascend and supply the regions that are actually above the thoracic spine. And it's reported that the fibers that supply the head come from T1 to T4, and the fibers that supply the arm come from T1 to T8. So it kind of fits with those thoracic segments that are spoken about in T4 syndrome. And on the diagram on the right, you can kind of see in a bit more detail how that happens. So you can see the red preganglionic sympathetic fibers coming out of the ventral horn, and that's with the somatic motor fibers as well. And then they kind of briefly join the spinal nerve. And then instead of traveling all the way along the spinal nerve, they actually exit through the white ramus communicans and enter a paravertebral sympathetic ganglion. And some of the fibers will synapse at that level and just rejoin the spinal nerve, but some obviously descend and some ascend up to their target level before synapsing. And then they'll rejoin the spinal nerve through the grey ramus communicans. And then they follow the peripheral nerve all the way to their target organs. And those white rami communicantes and the sympathetic chain actually cross the vertebral bodies in the rib heads. So depending on the type of spinal pathology and where the location of the spinal pathology, they can actually be affected separately from the somatic nerve. So you can have a case where you've got autonomic nerve dysfunction separate from the typical like radiculopathy symptoms that you see. So regarding literature on this condition, there's not a whole lot. I've just got the hierarchical triangle of the levels of evidence for treatment efficacy studies from the Oxford Centre for Evidence-Based Medicine on the right, to remind you of the different levels. And there has been one scoping review of the literature done for T4 syndrome, and they identified one level 2 randomized controlled trial, but that was more about the mechanisms of manual therapy rather than T4 syndrome itself. But it still is relevant, and I'll go through that in a bit more detail in a few minutes. Then there were 2 level 4 case series identified, but I think it was pretty generous to give them the classification of level 4. They both only had 2 patients included, and they didn't demonstrate great methodological rigor. And then there were 8 other pieces of literature included that kind of fell into the level 5 mechanism-based reasoning category, where it's really just the authors hypothesizing about how the results of their study could be plausible. And those kind of included singular case reports, expert opinion pieces, and some larger case series that weren't properly reported, like that Nick McGuckin one. And the take-home messages from this scoping review were that there's no high-quality evidence and it's all non-experimental, so you can't really draw firm conclusions about the condition. And if T4 syndrome exists, it's rare. So these are a couple of the case series and reports that I won't go through individually, but I've summarised the commonalities and I've included the expert opinions about the condition as well. So on top of the subjective features that I've already mentioned, the main assessment findings are that imaging is negative. So there's no specific spinal pathology that can be identified on scans that helps with the diagnosis of the condition. The aggravating factors often involved prolonged positions or repeated movements. So prolonged sitting is mentioned, and repetitive reaching and lifting and those kind of things. Postural abnormalities are a strong feature, and they're mainly talking about thoracic kyphosis and cervical forward head posture, but that did vary patient to patient as well. You often see pain and stiffness limited thoracic and cervical range of motion, painful and hypomobile thoracic segments on like PAVMs and an articular exam, potentially positive neurodynamic testing. And I put some asterisks next to neural integrity testing because the traditional descriptions of the condition and most of the literature say that there's no hard neurological signs, which makes sense because the sympathetic nerves don't supply the skin or the skeletal muscles. So it makes sense that you wouldn't be able to identify any signs of neural compromise on a clinical neuro exam. But there was one study that demonstrated like reduced sensation detection thresholds on quantitative sensory testing, as well as reduced grip strength. So just to be aware of that. And then the main interventions that were included were thoracic and rib mobilizations and manipulation, which was the most common and reported to be the most effective. And they were complemented by thoracic range of motion exercises, thoracic extensor strengthening, pectoral stretching, postural re-education and motor control type exercises, and then activity modification to minimize symptom aggravation, and addressing any cervical joint and muscle impairments that are identified as well. I've just put some asterisks next to anesthetic injections and adjuvant analgesics, because there was one study, it was the one by Melick and Melick that I've got on the screen there. And it was the same study that identified the numbness and the weakness. And what they did was inject local anesthetic into T4. And they reported immediate but short-lasting relief of all the symptoms, including the paresthesias, the numbness and the weakness, which I couldn't make sense of physiologically. They had some interesting hypotheses about supraspinal kind of inhibition, the spinal pain causing supraspinal afferent input inhibition and motor output inhibition, but at a dermatome and myotome that's quite far outside the T4 dermatome and myotome. So there are also some other concerns with that study. The patients progressed to having cervical epidural blocks, which reportedly helped their symptoms as well. And they were on gabapentin and they were whiplash patients. So there's a concern there about the diagnosis, and you can't really pull out which intervention was effective. But the rest of the studies generally report positive outcomes ranging from immediate to gradual improvement in all symptoms in response to the conservative physio interventions that I've got listed on the screen there. But all the studies had common limitations as well. Obviously, small sample sizes of 1 to 2 patients, no control group, so you can't really rule out just the natural history of the condition improving, and you can't rule out the non-specific contextual effects of the intervention either. There were no objective measures of improvement, just subjective patient reporting that the symptoms are improving, basically. There's the obvious issue with the diagnosis of T4 syndrome, and they didn't actually measure sympathetic nervous system activity. So there's no actual evidence that T4 syndrome patients have reduced sympathetic nervous system activity. It's kind of just based on the subjective symptoms matching autonomic nerve dysfunction and the plausible pathway between the thoracic spine and the upper limb and the head via the sympathetic outflow. So this was the one randomized controlled trial that was featured, but it doesn't actually involve T4 syndrome patients. It was done on healthy patients. But what they did was a PA rotary passive accessory mobilization to T4 to see if they could affect sympathetic activity in the hands. And they measured skin conductance and skin temperature. So skin conductance refers to the amount of electrodermal activity in the skin, where an increase in sympathetic nervous system activity stimulates the sweat glands to secrete sweat, which increases the skin's conductance to electricity. And then similarly, an increase in sympathetic activity causes vasoconstriction of the peripheral blood vessels, which decreases skin temperature. And they found that mobilizing T4 did increase skin conductance and decrease skin temperature in the hands compared to a placebo manual therapy technique. And that kind of poses the question, does that prove the proposed mechanism of T4 syndrome? And the answer is not necessarily. So even though that might seem intuitive, you have to be careful about how you interpret those findings. So they hypothesized that they achieved sympathoexcitation through stimulation of the periaqueductal gray, which is an area area in the midbrain that acts as a common pathway for the sympathetic nerves, afferent and efferent somatic nerves, and monoamine analgesic pathways. So it's really just a demonstration of the generally accepted mechanism of manual therapy. So rather than representing a direct link between T4 and a hand, these findings more likely represent the manual therapy being an afferent input that stimulates the periaqueductal gray and then causes a supraspinal response that increases sympathetic activity that may be systemic. But I think what it does do is provide evidence for a mechanism to normalize sympathetic activity in T4 syndrome, if that is in fact the mechanism of T4 syndrome, that it's reduced sympathetic nervous system activity. So it may be why clinicians report positive outcomes from using manual therapy on T4 syndrome patients. So onto the diagnostic considerations for T4 syndrome. Obviously, there's no reference standard. Like I mentioned, there's no imaging that can identify any specific pathology to help with diagnosis. There's no standardized clinical diagnostic criteria. There's no special tests that you can do to help with your diagnosis. Most of the literature agrees that there's an absence of neurological signs, so nothing shows up on a neuro exam. Sympathetic activity is obviously difficult to measure clinically, but remembering that hasn't actually been objectively substantiated as a feature of T4 syndrome. And then you've got a complex list of differentials that can be almost as difficult to define and rule in or out as well. So all of that obviously makes making the diagnosis really difficult clinically, and also makes doing any sort of high quality research on the condition almost impossible. So just regarding the differential diagnoses that you have to be aware of, obviously angina pectoris is the big one, also known as just somatic referred cardiac pain. And that's obviously caused by convergence of the cardiac visceral afferents on common secondary somatic afferents. And that's usually mediated by the intercostobrachial nerve, which is a branch off T2, and it supplies the axilla and the chest wall and the arm. So it kind of causes that typical pain referral in cardiac issues where you get chest pain and left arm pain. And then you've got entrapment neuropathies. So lower cervical radiculopathy or radicular pain would be the most common, that kind of mimics those upper limb neurological symptoms. And radicular pain would be even trickier to differentiate because you've also got that lack of neurological signs, and neurological neurodynamic testing can be positive in both radicular pain and reportedly in T4 syndrome as well. Obviously, the other upper limb peripheral entrapment neuropathies you'd have to consider as well, like cubital tunnel syndrome and carpal tunnel syndrome. Then you've got cervical myelopathy. So that's one that can commonly cause bilateral upper limb neurological symptoms. You'd have to be considering that. Thoracic outlet syndrome is the other big one. So obviously you can have vascular or neurological subtypes. The vascular subtype can mimic the vasomotor symptoms that you might have that you see in T4 syndrome. And the true neurological subtype might be easier to differentiate because you will have signs of a neural lesion, but the vast majority of thoracic outlet syndrome presentations actually fall into the symptomatic category, where there's also no sign of neurological compromise. So it's notoriously difficult to diagnose and rule in or out in itself. And then regarding the headaches, obviously you've got myriads of primary and secondary headache classifications that you'd have to be able to confidently rule out. And I think pinning one on T4 would be quite difficult. So coming to the conclusion and clinical implications, does T4 syndrome exist? I think it's definitely, there's a neuroanatomically plausible pathway. It's definitely possible, and I can't rule it out. But I think the current evidence doesn't adequately legitimize it as a discrete condition, as opposed to a constellation of symptoms that involves a complex interplay of multiple regions and multiple systems. And the clinical take home on what you should do if you suspect T4 syndrome, I guess the main thing would be aware of the differentials and make sure you're ruling them out to the best of your ability and that you're not missing anything. But at the end of the day, it's treat the impairments. So there's going to be joint signs in the thoracic and cervical spine. So you want to be restoring range of motion, reducing the pain, modifying the activity to reduce symptom aggravation, and, you know, postural re-education, all those types of things. So really the assessment and management doesn't look any different to your regular musculoskeletal assessment and management. And that's all I've got. So thank you. If there's any questions.
Wonderful. Thanks, Zach. There are a few questions in the Q&A, so if you could just open the panel and have a look. And it'd be good to just rephrase the question for the rest of the audience as well while you're answering.
Yep. So Tarquin's asked, what's the actual mechanism of pain and paresthesia if the sympathetic nerves are affected? Yeah, so I had the exact same question, and this is what I was tearing my hair out trying to figure out the neurophysiology of. So because obviously the sympathetic nerves are efferent, they're motor nerves, so they're not sensory. So where does the pain come from? And I don't think it's something that anybody has confidently figured out yet, but the theory that makes the most sense to me is through the general visceral afferents. So they're not technically classified as part of the sympathetic nervous system, but they're a part of the autonomic nervous system, and they travel alongside the sympathetic efferents. So they run through the peripheral nerve and through the sympathetic chain, and they just split right as they enter the spinal cord. They go into the dorsal horn. But theoretically, if the sympathetic nerves are being affected by some sort of spinal pathology, you'd think the general visceral afferents would also be affected, and they would create pain and paresthesia kind of through their distribution. There's also some other kind of more complex theories about sympathetically maintained pain that mainly comes from research about complex regional pain syndrome, about how you can get convergence and interaction between the sympathetic efferents and the somatosensory nociceptive fibers. And the neurophysiology there goes over my head, but yeah, there's a few theories, and I don't think it's been figured out fully yet. Erin has asked, how did they justify the diagnosis in the studies that you mentioned? Yeah, it was basically just they matched the subjective features mainly, so they all had spinal pain, as well as headaches and upper limb neurological symptoms, and they spoke briefly about how they ruled out the differentials. So they kind of said cardiac referral would have the other symptoms of a heart attack, so diaphoresis and exercise related aggravation and things like that. And they used like the Adsons and the Wright's test to rule out thoracic outlet syndrome, but if you actually look at the diagnostic utility of those tests, it's not that great. They're like between sensitivity and specificity between like 50 and 70%. So you can't really hang your hat there.
Zach, just a moment. We've got someone in the audience with their hands raised, so I'm going to allow them to talk because I am assuming that they would like to ask a question. So Rebecca, would you like to ask your question? I think I've unmuted you. You can try unmuting and see if you can actually speak. Or maybe that was an error, I'm not sure. Okay, let's move on to the next question in the Q&A panel then.
Yep. Eric has asked, can you comment on the bilaterality of the presentation when the sympathetic chain is actually bilateral? Yeah, so again, a complex kind of neurophysiological concept where, yeah, you're potentially getting some sort of convergence or supraspinal convergence. And you're right, like in those manual therapy studies, they show increased sympathetic nervous system activity usually on both sides. One's usually stronger than the other, but you do see increases in sympathetic nervous activity on both sides. So yeah, it's an interesting concept, and I can't answer it perfectly for you. It's quite complicated. Mark's asked, is there any correlation between T4 syndrome and neurogenic thoracic outlets? No direct signs. There appears to be significant overlap. Yeah, so that's what I was talking about, how the vast majority of thoracic outlet fall into that symptomatic category where there's no demonstrable neurovascular lesion. And so, yeah, it is quite similar to T4 syndrome in that you've got these vague kind of neurological symptoms that you can't actually pin down to a specific pathology. And yeah, so big overlap. And I think that's probably the hardest one to be able to confidently differentiate. And because the T4 syndrome reportedly involves the cervical spine as well, the cervical aggravating factors versus the thoracic aggravating factors in terms of what movements kind of do it doesn't really help either. So, yep, that's a hard one. Physiotech has said, how would you educate the patient regarding T4 syndrome if you suspect this is a hypothesis? I think being honest, that, you know, it's not fully understood, but explaining that there is an anatomical link between the thoracic spine and the upper limb and the head, and that even though there's no high quality evidence, the literature that is available kind of suggests that they have a fairly positive prognosis, and most of the studies said within a month of commencing manual therapy to the thoracic spine that the symptoms had completely resolved or near completely resolved. So yeah, just kind of conveying the elusive nature of the mechanism.
Okay, we have a raised hand. So Tarquin, I've unmuted you, so if you would like to ask your question.
I think,
Or maybe
yeah, Tarquin had asked the first question. I might have answered.
Okay.
Oh yeah, that was a mistake. Ruth has asked, do you think imaging is necessary to rule out differentials, or would you get imaging? Yeah, that's an interesting question as well. I think for research purposes, if there was to be a high quality or as high quality study as possible to be done, I think you would do imaging to try and identify things like any nerve root compression or myelopathy or anything like that. Clinically, I don't think it would add that much because, like I said, most of the differentials are also non-specific. So, for example, the symptomatic subtype of thoracic outlet syndrome is not going to show up on imaging either. So in reality, in clinic, no, I don't think I would image unless there was indication for something more sinister that I'd be trying to rule out. Just a comment and compliment. Thank you very much, Kylie. And
right. I think that's all the questions that we've got. And we're just about time, so that's pretty good timing. Thank you everyone for all the interesting questions, and thanks, Zach. So the last person we have, but not the least, would be Sim. So Simran, would you like to share your screen, please? Okay, so Simran works in private practice on the north side of Brisbane and has been there for over the last 5 years or more. And while there, most of the caseload is lower limb cases, and she's really developed a love for treating these lower limb injuries. And in the recent few years, she has treated a few of these Lisfranc injuries and found them particularly challenging to diagnose and commonly missed with some significant repercussions. So therefore, the topic that she's covering today is on Lisfranc injuries. So now, Sim, we can see your presenter view. So we might need you to swap the screen share again and see if we can get the right screen showing.
Sorry about that. Thanks, Yuki. And thanks to everyone for staying back late on a Friday night to discuss all things Lisfranc and why they are so oftenly missed and poorly managed. So you guys, hopefully after this 20 minutes, will never make the same mistake I once did in my second year out, where I missed one of these injuries. So, can you believe that between 20 to 30% of Lisfranc injuries, majority of these low grade are initially missed? 3 different retrospective studies with moderate sample sizes in each study, as referenced below here on the screen, from 3 different continents across the world, including many health professionals from ED doctors to GPs and physiotherapists, highlighted similar figures, indicating that misdiagnosis of Lisfranc injuries is a global issue and spans across the health field and needs to be addressed. Mayich and colleagues in 2012, through another retrospective study, indicated that in the States, it was the most missed orthopedic injury in ED. So let's explore how we can be part of the solution and not add to this percentage of misdiagnosis. So Lisfranc dislocations and fractures only make up about 0.2% of all fractures, with the vast majority being in males. So a lot of the time, it is not at the forefront of our mind when diagnosing foot and ankle pathologies, especially in females. It is commonly misdiagnosed for a midfoot sprain or just a really bad lateral ankle sprain or an isolated metatarsal fracture or a navicular or cuboid fracture, sometimes even a tibialis posterior injury. However, for Lisfranc injuries, while it is important to have accurate diagnosis throughout the body, it is especially important for the Lisfranc complex. The Royal Australian College of General Practitioners classifies a Lisfranc injury as a red flag in general practice due to the debilitating outcome of these injuries, especially if poorly managed. On this slide here, we can take a look at the short-term effects to the potential long-term dire consequences that could occur due to misdiagnosis. In the short term, we can see with higher grade injuries, you can get compartment syndrome in a decent percentage of these, along with nerve and arterial pathologies. In low grade Lisfranc injuries, there is a risk of getting that secondary diastasis, and towards the long term, we can develop that pes planus deformity, chronic foot pain, or even midfoot arthritis. But we'll be delving further and deeper into the anatomy, the mechanism of injury, and we will revisit this slide at the end so we can fully understand how these consequences can occur. So let's start off with the anatomy of the Lisfranc. Many people, including myself, when I first became a physiotherapist, were under the impression that the Lisfranc is just a ligament, which connects the first and the second metatarsal. However, this is very untrue, and it is a complex joint, bone, and ligamentous complex. The Lisfranc complex is broken into 3 longitudinal columns as highlighted on the image in the left corner. We can see the column 1, the medial column in blue, consists of the medial cuneiform in the first metatarsal. The central column consists of the intermediate and lateral cuneiforms, along with the second and third metatarsals, highlighted in green. And then the lateral column is the cuboid, along with the fourth and fifth metatarsals, highlighted in yellow. This complex also consists of 3 ligaments. Firstly, the dorsal ligament, as seen on the right of your screen, which attaches the medial cuneiform to the second metatarsal at the front. This is also the weakest of all the ligaments. We then have the interosseous ligament in the middle, otherwise also known as the Lisfranc ligament, which is what a lot of people think is the whole complex itself. And then we've also got the plantar ligaments which attach at the back there as well. We also must consider some of the secondary muscles that also act to stabilize this region, including the peroneal longus, the flexor digitorum longus, the tibialis posterior, and the flexor hallucis, all of which also contribute to the mechanism and the function of this region. Now that we have the basic anatomy hopefully down packed, there are some key anatomical considerations I would like to flag. Firstly, the deep peroneal nerve and the dorsalis pedis artery run through this Lisfranc complex. The dorsalis pedis artery is the primary source of blood flow to the foot. And with your severe Lisfranc injuries, there is a risk of this being disrupted, especially if it is not picked up early and appropriate intervention is not conducted. Secondly, we've also got that between the first and second metatarsal, as you can see on your screen, There is no intermetatarsal ligament, and it is the only one of the metatarsals with no intermetatarsal ligament, which makes it the most prone to dislocation and injury. Other thing we must also consider is there is very minimal motion between the first to third metatarsal articulations with the cuneiforms, which is necessary as the primary purpose of the Lisfranc complex is the stabilization of the arch for the push-off phase during the gait. It also helps transfer loads from the lower leg into the calf and foot when you're running or walking. So therefore, if we have disruption to this area of the foot, we can see how that could cause a pes planus deformity as we are losing the main stabilization for the arch in that part of our foot. If we now go over the Lisfranc mechanism of injuries, we have a high energy and low energy mechanisms. Low energy ones are often associated with impact sport, and they're the ones that are usually missed. They usually occur when the foot is in plantar flexion, because this is when the dorsal ligaments, which we saw on the earlier slide, are in their most weakened position. So then what can happen is we can have direct force that is applied, as you can see where that dotted line is, or a strong axial rotation force as well, and that can cause injury to this region. We also have here that the high energy Lisfranc injuries. These account for 60 to 70% of the injuries, and they're usually related from a significant traumatic event, whether that be a motor vehicle accident or a crush injury or a fall from a significant height. And these are the ones that are not as commonly missed. So now that we have gone through some of the basics, and hopefully we're all clear on the Lisfranc anatomy and the mechanism of injury, I'd like to look at some key examination signs to help us diagnose these injuries. So looking at two recent articles, one of which is a systematic review by Chen and colleagues in 2020, and the other a literature review by Carter and colleagues in 2023. The four findings on the left under the patient interview heading appear to be the primary consensus for Lisfranc injuries, which include difficulty weight bearing, edema and swelling over the dorsal foot, plantar midfoot ecchymosis, or midfoot and midfoot pain. The plantar midfoot ecchymosis is the most rare of the lot and has the strongest link to the presence of a Lisfranc injury. If we move towards the physical exam, they mention tenderness on palpation of the first and second tarsometatarsal joint, along with pain on the compression of the foot. The special test commonly mentioned in the literature is the piano key test, where if we pretend my hand is the foot for a second, it's where we dorsiflex and plantarflex each of the metatarsals and expect pain or a popping sound to be reproduced at the joint. This test is the most common special test mentioned in the literature. However, there is no study that looks into the efficacy and the reliability of this special test. So we have been using tests that don't actually really have much evidence to back them up. Furthermore, a survey conducted by Rossi and colleagues in 2021 looked at over 200 orthopedic residency directors, looking at their familiarity with the test and how they performed it. 30% of them didn't even know the test existed, and the other 70% reported 4 different methods to complete the same test. Therefore, if we don't really have too many validated physical exams, what do we have to help prevent this issue of poor diagnosis of the Lisfranc complex? That takes us to imaging, which has the strongest evidence. Systematic review by So and colleagues in 2023 indicate that MRI is the gold standard with excellent diagnostic accuracy. 3 retrospective studies that were included in this systematic review showed 100% correlation between MRI findings and intraoperative findings. A close second is a weight-bearing CT, which has a high utility in identification of Lisfranc injuries, particularly when comparing injured and uninjured side. One of the retrospective studies within this systematic review again highlighted that a bilateral weight-bearing CT scan picked up 12% more Lisfranc injuries compared to a bilateral weight-bearing X-ray. Lisfranc injuries, however, a weight-bearing X-ray is still more beneficial to detect subtle injuries compared to a normal X-ray. A normal radiograph is not a valid diagnostic tool for a Lisfranc injury on its own. So if we can go into an example, this was a bilateral weight-bearing X-ray, where in the referral details, all that was written was question mark midfoot pain. The radiologist report came back, as we can see at the top there, normal anatomical alignment and symmetry of the tarsometatarsal joints. However, when we look closely, there is a widening of the first and second metatarsal, as you can see by the purple arrow, subtly extends to the medial and intermediate cuneiform. Another retrospective study by Sharif and colleagues provided 30-foot radiographs, of which 18 had Lisfranc injuries. It was presented to 9 senior radiologists, and only 61% were able to identify all 18 images. It was concluded that a strong clinical index of suspicion that was clearly demonstrated in the referral information on the imaging form assisted with accurate diagnosis. So it is essential, if we are referring for imaging suspecting a Lisfranc injury, we must state that in our referral information. Now I'd like to go and look into some classification systems that have been validated for the Lisfranc complex. The Hardcastle and Meissen classification system is the primary classification utilized to grade the severity of Lisfranc injuries. It is shown to have good intra and inter-rater observer reliability. However, we can see it only factors in severe fractures and dislocations and does not even mention low-grade Lisfranc injuries, which make up 40% of this population, as we can see by the type A, B, and C, all of which are demonstrating dislocations or fractures. None are demonstrating a stable Lisfranc injury. If this is the primary classification system used in our hospitals, then it makes sense why so many of these lower grade Lisfranc injuries are going unnoticed. So I'd like to bring your attention now to the Nunley and Vertallo classification system, which was proposed about 15 years ago for low-grade Lisfranc injuries. However, there is minimal evidence into its utility and reliability. There was a study conducted on 15 athletes who were treated based on the criteria indicated on the screen, where if there was a sprain to the Lisfranc or the interosseous ligament and no diastasis or a diastasis less than 2 millimeters between the medial cuneiform and the second metatarsal, it was managed conservatively. If this diastasis was greater than 2 millimeters, surgical management was utilized. They had excellent results, with the 93% of patients returning to higher level sport within 12 to 18 months. However, we should note that this study had a small sample size and was dealing with an athletic population. But it appears that this study did have a marked impact on research, because moving forward, majority of the articles have used a similar staging to determine whether conservative or surgical management should be utilized. So let's now delve into a little bit about what does management actually involve for Lisfranc injuries. The big question for Lisfranc injuries is, does conservative management actually hold a place? Well, the answer is yes, for those stage 1 injuries that I mentioned on the previous slide, where there is purely a ligamentous injury with a diastasis of under 2 millimeters between that medial cuneiform and the second metatarsal. However, regular re-imaging is required to monitor progress. This was really highlighted in a systematic review by Chen et al. And colleagues for maximal outcomes in conservative management. However, if there was a greater than that 2 millimeter diastasis, then surgical options were the best outcomes. Either an ORIF, or if that doesn't progress well or there is a significant damage to the complex, a midfoot fusion. For conservative management, there have been a couple of studies released, as highlighted in REN 2019, that actually look at not having the patient non-weight bearing in the first 6 weeks and actually weight bearing after 2 weeks. However, this did result in significantly worse outcomes for the patient. So it is essential, if we are managing this injury conservatively, that we are non-weight bearing for the first 6 weeks, weight bearing in a moon boot for the next 6 weeks, followed by, after that 12-week period, walking in shoes with the custom orthotic, and we're not looking at a return to sport timeframe for at least 12 to 18 months. So now if we go back to where we started about what are the impact of misdiagnosis and why is it so important to pick up these Lisfranc injuries early on? What we've done here is in this slide here, I've noted that conservative treatment for those grade 1 injuries had positive functional outcomes as per a systematic review by Guerrero and colleagues in 2023 at a 2-year follow-up. And this was based off this was done and assessed 5 retrospective studies within this systematic review. And they all said that they had great outcomes at 5 years. However, there were 3 studies within this systematic review, again, retrospective studies, that saw poor outcomes with conservative management. And this was because on further review of these studies, this was because of 3 main reasons. Patients were not kept non-weight bearing for the first 6 weeks, and this allowed and caused that secondary diastasis, so that widening greater than 2 millimeters between the medial cuneiform and the second metatarsal. 2 of the other studies relied purely on plain radiographs, which, as we discussed, is not actually an appropriate diagnostic utility for low-grade Lisfranc injuries. And this led to inaccurate diagnosis of the severity of the injury initially, and these patients then required surgery. And one of the studies conducted used CT scans, but they were non-weight bearing. And when they were then completed in a weight-bearing position, there was a dynamic instability of 3 millimeters, which further highlights the importance of a weight-bearing scan being the best option for these Lisfranc injuries if an MRI is not accessible. So in order to have positive conservative functional outcomes, it really is important that we get the correct grading of injury at the beginning. Now, if we look at surgical management prognosis, Chen and colleagues in 2020 clearly highlight that those that have surgery after 6 months post-injury have much worse functional outcomes at the 2-year mark, with majority of these patients in constant midfoot pain, unable to walk for long periods of time, and there are significant impacts on their quality of life. Surgical intervention within the first 6 weeks in this study had the best functional outcomes. The evidence is a little bit mixed on the consequences of delayed surgery between 2 to 6 months post the injury, with some studies saying there are still great outcomes and others saying that it needs to be within the first 6 weeks. But it is hypothesized that longer time periods between injury and surgery can result in further articular cartilage loss, chondrocyte damage, and may increase the number of affected joints, worsening the overall outcome. So if we go back to this slide that we talked about at the start and the potential consequences of misdiagnosis, now that we've run through the anatomy, the mechanism of injury, and the effects of delayed diagnosis, we can clearly see why it is so important for the Lisfranc especially to get the grade and the severity of the injury right at the start. In the short term, especially if conservative management is selected, we run the risk of secondary diastasis, which could lead to surgery, and delayed surgery can lead to poorer functional outcomes in the future. As well as if we don't manage these appropriately early on, then they will not heal properly, causing that impact on the medial arch, losing its support system, increasing the likelihood for a pes planus deformity, chronic foot pain, and then in the future, midfoot arthritis as well. So I guess to take it home, the main kind of clinical message I want everyone to walk away with today is, as you can see, high-level research is lacking for the Lisfranc injuries, with majority of the research coming from retrospective studies. There are no randomized control trials comparing surgery and conservative management for those lower grade Lisfranc injuries. For higher grade ones, surgical is the only option. But what we do need to take away, and what we can take away with certainty, is to remember that the Lisfranc is not just a ligament. It is a complex interplay of ligaments, joints, and bones, and prompt and accurate diagnosis is essential. The signs that I've listed to the left of your screen appear to be the most consistent throughout the literature. If you are seeing any of these signs, 1 or 2 of them, or even have the slightest suspicion that there is a midfoot problem, there is difficulty weight bearing, you must image. As we've mentioned before, MRI is the gold standard. But if we don't have access to that, then CT scans or X-rays, as long as they are bilateral, so we have something to compare it to, and our weight bearing, as we discussed before, because of that dynamic instability that can occur, can still give us great outcomes. And if we do this, we can get early and accurate diagnosis, which is going to lead to the best functional outcomes for our patients. Thank you. So if anyone has any questions.
We've got several questions, Sim. So if you can open your Q&A window and have a look. And again, please remember to read out the question.
So Matthew mentions, are there any risk factors that increase the likelihood of Lisfranc's that we should be aware of? So yes, there is some literature out there that indicates that if there is kind of a shallow mortise between medial and lateral cuneiform, then, and that's kind of like smaller, then there is a higher likelihood of an unstable Lisfranc injury. And as well as the idea that if the ratio of the second metatarsal to the foot is smaller, so there were some retrospective studies that looked at those that had 50% less kind of ratio of their second metatarsal length to their foot were more prone to getting unstable Lisfranc injuries. So that is something we can look out for. There are the obvious ones which include diabetes, neuropathies, all those more kind of chronic conditions where when you have that sensory loss, and as we talked about the dorsalis pedis artery running through there as well, these are ones we have to be very cautious about because they may not be able to symptomatically tell us what is going on, and they are more prone to developing these injuries as well. And the other thing too is they are a lot more common in men, and they are very common in the athletic population in about the third decade of life as well. So sometimes with our athletic populations, Lisfranc's isn't the first thing that comes to mind with foot and ankle injuries, but it probably should. So that would answer that one there. So David mentions, when considering the delineation between surgical and non-surgical management of the 2 mm diastasis, what imaging modality was this measured from? So majority of the studies used either weight-bearing CT scans or weight-bearing X-rays comparing the 2 feet. So that was what was used. As the literature says, I think as I mentioned previously, CT scans do tend to pick up about 12 to 15% more Lisfranc's than the weight-bearing X-rays, but that was the imaging modality used to determine that. Cool. Thank you, Deb. Tim Duffy mentions, did you come across any evidence comparing conservative therapy to surgical therapy for those patients with greater than a 2 mm diastasis? Or have there been any studies demonstrating that patients managed appropriately conservatively, non-weighting a greater return, have poor outcomes? So to answer the second question, if it is under 2 mm, conservative management has proven to be as good as surgical management. I do not believe there are any studies out there that look at conservative management for those greater than 2 mm. Surgery has been recommended in those cases, unless there is another like medical contraindication or comorbid contraindication. So literature mentions if it's greater than 2 mm, they should be getting surgery. But if there is another comorbid issue, then they have hypothesized you can use a conservative approach with regular re-imaging, but I'm not sure what the long-term outcomes are, and I don't think that has been explored because I don't think that is a huge sample size of patients as well. Andrew, you mentioned the long-term impacts on quality of life. Are there any qualitative studies looking at the patient's perspective? Yes, I think this is a great question because obviously Lisfranc injuries do have, which is the whole premise of this presentation, do have that really long-term impact and can have those really dire consequences if misdiagnosed. However, there is very little qualitative research out there right now. There is a team in the Netherlands who are currently running the first RCT trial to determine if an ORIF or a fusion is the better first option for surgery. And they have actually run a qualitative study looking at like the past 10 years and going back in time and interviewing those people. And they have mentioned, but it was more to target what they wished was different from their treatment rather than how it's affecting their quality of life. But one thing from that study that we could probably take away for that is a lot of them were not prepared for, they felt unprepared for the length of recovery it takes post a Lisfranc injury. It's probably the longest recovery for any orthopedic injury in the foot or the ankle. And patients felt very unprepared for the length of time it would take to recover. So I think that is probably a patient's perspective that we as physios can really educate in, because we will be involved in their care, whether it's conservative or surgical. So I think that's something we can take away and really set that patient expectation up early so they understand how long a journey it's going to be. Anmol, thank you. Any thoughts on why return to sport for conservative care is around 12 to 18 months? Sounds like a long time. Does surgical management lead to earlier return to sport? Yes, it is a long time. The biggest concern is they are very conservative with return to sport and return to impact because of the risk of purely ligamentous Lisfranc injuries are very, very difficult to diagnose the severity of them. So they are very conservative with the return to sport approach to ensure that they can be certain there is no underlying instability prior to return. And especially in elite athletes, all of them will go through a rescan, usually at the 3-month, the 6-month, and then the 12-month mark, to ensure that there is no dynamic instability that is coming up as they are weaning out of weight bearing. But that's why it takes so long. Surgical management does not lead to an earlier return to sport. No, it's still 12 to 18 months in most cases. Andy, Lisfranc injuries are quite common presentation in ED. Often they are unable to weight bear, so weight bearing X-ray is not feasible. And a CT, as you mentioned, is non-weight bearing and where show ligamentous injury, only avulsion fractures, etc., that might be suggestive of this. Therefore, how do you suggest this be managed acutely, given MRI is typically not available? This is a great question. Firstly, the first recommendation would be if you have access to a CT scan, which I respect is resources are an issue, even a non-weight bearing CT scan is a lot more effective than a X-ray. So that would be the first way to target it. The second thing is if you are suspecting a Lisfranc injury, it is important that they remain non-weight bearing. A lot of the time what happens in ED is they're given a moon boot and they're told to mobilize in their moon boot. But with a Lisfranc injury, you're not allowed to weight bear for 6 weeks. So if you don't have access to an MRI, or even a CT scan, and the best you can do is an X-ray that comes back clear. Trust your clinical instinct, as we talked about with the subjective and physical exam findings, and inform them to be non-weight bearing until the pain is able to settle, so they can then get a weight bearing scan or an MRI. And this is a huge reason, as I mentioned at the start, why like in America, that retrospective study showed that low-grade Lisfranc injuries were the most missed orthopedic injury. So that is how I would manage it. But the key is keep them non-weight bearing if you even have the slightest inkling that it could be a Lisfranc till they can be imaged. Cool. Thanks for covering this topic. Liz Paul, you mentioned a custom orthotic is needed later in their rehab. What features are needed in this custom orthotic? So they need basically great medial arch support. As they are weaning out from, you've been non-weight bearing for 6 weeks, they've been weight bearing in a boot for 6 weeks. For the next 6 to 8 weeks, they're not allowed to walk barefoot. And they're only allowed to walk in good footwear with appropriate medial arch support. So the custom orthotic, if you're able to, majority in my experience treating these injuries, usually the specialist has fitted them with one. So whether their foot molds to one that the specialist has available, that's fine. But usually everyone recovers differently, has different arch heights. Usually they are molded because they need to fit exactly their arch, because that first 6 to 12 weeks when they've weaned out of a moon boot and gone into footwear are super, super important to prevent that pes planus deformity. But if they're able to get good arch support not requiring a custom orthotic, then they don't need a custom. They can buy over the shelf.
Wonderful. Well, that's taken us up right to 8 o'clock sharp. So thank you everyone for attending, and I hope the sessions have been interesting and useful for all of you. I'm wishing you a good weekend ahead and a nice evening. Thank you everyone. Bye-bye.